hard. Okay. Ah. I was not supposed to show that. It ain't working. 16, 17, 21. Let me see if I can. Oh my god. We have contracture, receive flexion, orthopaedic, orthostatic hypertension, position of function, shearing, associated intended to physiological and psychological changes can be a consequence of immobility. In this chapter, we will help you determine what to do for patients with immobility and mobility problems, and how to prevent further complications from immobility. Effects of immobility. Immobility occurs in the lack of activity in movement. Which may occur if a person is ill and is less active than usual. When movement is restricted, body systems immediately react as they continue to react as long as the immobility persists. And when a patient is placed in prolonged bed rest, what's a lack of? Prolonged bed rest for reasons such as coma, multiple trauma, long intensive care stays, severe weakness, and overwhelming infection. Even more complications can arise. However, it is important to recognize that complications resulting from bed rest and immobility, although numerous, are preventable. It has been recognized for many years that immobility to prolonged bed rest can be as early as 1947. Article about the dangers of immobility was published in the British Medical Journal in 1967. The American Journal of Nursing published the often cited article, The Hazards of Immobility, detailing the effects of immobility on each body system. Prior to these publications, it was common for medical authorities to prescribe strict bed rest. It was common for medical authorities to prescribe bed rest for many days and weeks. Now we know that the longer a patient remains inactive, the more he or his or her changes of developing complications increase. So these complications include blood clots, pneumonia, bone demineralization, kidney stones, constipation, pressure injuries, urinary retention, depression. Fucking bozo. Okay, you as a nurse, let me see if I can I really need to bring that restream just for my own attention. Okay, let's get back to the shit. So we have blood clots, pneumonia, bone demineralization, kidney stones, constipation, pressure injuries. So how many of those? Blood clots, that's cardio. Pneumonia, so blood clots is cardio. Pneumonia is respiratory. Bone demineralization is skeletal. Kidney stones is skeletal to urinary. Constipation is GI. Pressure injury is skin. Urinary retention is urinary. Then depression is psychological. Psychos. Okay. You as a nurse have an important responsibility for ensuring the complications. Okay. You as a nurse have an important responsibility for ensuring that complications resulting from immobility are minimized, maintaining patient mobility when possible. Insurance won't pay for immobile. What the fuck am I spelling? Immobile. Insurance won't pay for the shit. Okay. Psychological effects. It is essential that the body remains active to optimize all functions. As a nurse, you'll be responsible for anticipating and minimizing effects of immobility to patient. Physiological. Table 16.1 summarizes the effects of immobility in the various body systems. Effects of immobility on the musculoskeletal system. When a patient is unable to move, he or she can suffer from muscle atrophy. Muscle atrophy, which means the muscles decrease in size, tone, and strength as a result of disuse. Along with muscle tissue, connective tissue such as ligaments and tendons undergo structural and physical changes after 4 to 6 days of immobility. So we have muscle tissue, connective tissue, and ligaments. Tendons undergo structural changes and functions after 4 to 6 days of immobility. These changes lead to joint inflexibility. Decreased range of motion and contractures, or shortening or tightening of the muscles when in disuse. Shortening and tightening of the muscles due to disuse. There it is. That's the word disuse again. Disuse is like what the fuck is a contracture, huh? A permanent or tightening of the muscle tendons or nearby issues. These joints tighten and become very stiff. Oh, so I got a contracture right here, huh? No fucking shit, huh? No fucking shit. Okay, so this is why your muscles feel weak when you've been ill and you have been remained for bed for several days. Osteoporosis is the condition that occurs due to a lack of bone minerals. It leads to the increased risk of skeletal fractures. Because that's structural. Immobility increases the risk of osteoporosis because a lack of activity and weight bearing results in a loss of calcium from the bones. Okay, so immobility increases the risk for osteoporosis. Okay, immobility increases the risk of osteoporosis because a lack of activity and weight bearing results in a loss of calcium from the bones. This bone demineralization can begin as early as 2 days, 3 days set from onset immobility. So we have 4 to 6 days for tendons and bones and shit, muscles, 2 to 6 days For bones, the calcium leaves the bones and enters the bloodstream, places the patient in increase of kidney stones because the excess calcium in the blood must be filtered out by the kidneys. Okay. Nursing measures to prevent this. The most basic nursing measure to prevent musculoskeletal pressure is to maintain body. Okay. Complications is to maintain proper body alignment, which means keep the head, trunk, and hips positioned in a straight line. The legs should be positioned so the toes point in the same direction as the anterior or ventral side of the body. This is accomplished by preventing the legs from rotating in the hip sockets medially. So like Eugene and his legs. It sinks into the hip. Gravity takes the toes. Okay, so we have, I said 8. 1, 2, 3, 4, 5, 6, 7, 8. 8. 9's physiological. 7 body. 1 mind. Okay. So what do we got? We have musculoskeletal. Okay, I don't know why I thought both of them are different. I guess they're the same. We have cardiovascular, the bloody, the respiratory, the breathy, the GI, the shitty, the US, the pissy, the skin, the blacky, the the nerves, the smarty, and the sociological, my depression. Let's get it. Depression. Okay. What do we got? We have musculoskeletal. The effects of immobility on the scully. Okay, we have muscle atrophy. This is called muscle atrophy. Decreased muscle strength and mass. Shortening and tightening of the tissue. This is called contracture. Alright. Oh my god, I'm actually so smart. Muscle atrophy. Shortening and tightening of the connective tissue. This is called a contracture. It's called a contracture. Calcium leaves the bone. Bone demineralization. It's called bone deminer. How the fuck do I spell it? AKA osteoporosis. Okay. Resulting in weak and brittleness. Breaks. Skeletal. Fracture. Okay. Oh, my skin! Ah!
Cardiovascular, decreased cardiac output. What do we call that? What is the medical term for decreased cardiac output? Huh. What is decreased cardiac output mean? Decreased cardiac output, medical word. Come on, someone give me the medical term for decreased cardiac output. Okay, cardiac output. Okay, decreased cardiac output. Orthostatic hypotension. Okay, what the fuck does that mean? Orthostatic hypotension. How does my fucking thing hear me? The form of low blood pressure from standing up or sitting or lying down because of immobility. Okay, a form of low blood pressure, decreased cardiac output is the decreased cardiac output the same as decreased cardiac output the same as low blood pressure? Thus, low blood pressure may be a result of reduced cardiac output. Okay, so cardiac output is how much blood you're pushing out? Whatever. Decrease. Let's not overthink it. We have decreased. Okay, oh my god, I gotta fucking these words. Orthostatic hypotension. What does this mean? This means decrease in systolic pressure or decreased in blood pressure. Form of blood pressure, low BP that happens when sitting or lying down. Okay. Pooling of the blood in the extremities. Okay, let me get this money. Okay. We have musculoskeletal, scully. We have cardi. So, pooling of the blood of the lower extremities. Chronic venous insufficiency. Chronic venous insufficiency. Maybe blood clot. Increased cardiac workload.
So we have blood clots in the extremities, blood clots traveling to the heart or brain, like stroke. Think of stroke. Increased cardiac workload.
Works harder. Okay. Respiratory.
Decrease pulmonary strength and decrease lung expansion.
So is that pulmonary atrophy? Is that what that is? Pulmonary atrophy. Limb muscle characterized as atrophy by is weakness amongst COPD. COPD. Chronic obstructive pulmonary disease, bronchitis is a COPD. A group of lung diseases that block airflow or make it difficult to breathe. Chronic obstructive pulmonary disease, COPD. COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. So like, think of pulmonary atrophy. Impaired oxygen and carbon dioxide exchange. So what is okay. What else do we have? We have acellulosis. What is this? Complete or partial collapse of lung. What the fuck? Complete or partial collapse of lung? Yo, this shit is fucked up. This shit is so sad. Hypoxemia? Oh no, what can that mean? Hypoxemia? No, what is this? Okay, it's spelled hypo XEMIA. There we go. Hypoxemia is below normal level of oxygen in your blood. Okay. Low O2 in blood. Hypostatic pneumonia. Not moving. Hypostatic pneumonia. Let's actually figure out what that means, though. Hypostatic pneumonia is a result of the pneumonia. Okay, pneumonia that usually results from the collection of fluid in the dorsal region of the lungs. That's what? No. So what is Pneumonia. Infection that causes inflamed air sacs of both or more lungs. So what is inflammation? Is just more ew. So pneumonia is an infection or one of both caused by bacteria or virus or fungi. So pneumonia is inflamed. So pneumonia means inflamed alveolar, right? Air sacs alveolar. Pneumonia. So hypostatic pneumonia. So hypostatic pneumonia? What the fuck does that mean? Definition. Can I get like a definition of pneumonia? Okay, so pneumonia condition due to the stagnation of blood or so just like the buildup of just the buildup. So it's just a buildup. Build up of inflammation. Okay, pooling of respiratory secretions. That's pneumonia. Okay, so that's like pooling of respiratory. So that's hypostatic pneumonia. Okay. Gastrointestinal. So decrease in peristalsis. So like the digestion rate. Decreased appetite. I don't know how it's gastrointestinal. That's like increased intestinal gas. Oh, he got dur. Just like the lubrication, so it's like hard poop. Flatulence. Farting. Distension is like of what? Wait. Of what? Urinary. Man. I have ripped this page apart. Urinary. Pooling of in renal pelvis. Urinary tract infection. That's literally what happens. Incomplete or emptying of the bladder. Increased calcium in the blood to be filtered by the kidneys. Skin. Decreased oxygen in the skin, nutrients and nutrients to tissues, so pressure injuries. Skin getting squished. Skin and capillary, so skin and capillaries catastrophe. Yeah, the
negative feedback loop. Feedback loop.
Okay, neurological. Decreased oxygenated blood. So decreased oxygenated blood being circulated to nerves trapped between the bed and the bone. Decreased in normal cues and activities. Decreased in balance when initially out of bed. So we have compression neuropathy. So what is that? Compression neuropathy. Okay, so suffering. So suffering. So compression neuropathy. Compression syndrome is a medical condition caused by a direct pressure on a nerve. Decreased oxygenated. So compression neuropathy is actually decreased oxygen. Okay, trapped nerve. Trapped. So the nerve is trapped. And the nerve, if the nerve's trapped, it's not getting anything else too, so. Also a byproduct. And then these two. Impaired level of consciousness and confusion. Okay. Psychological effects. Decreased normal and social interaction. It's not. That's pretty normal. This is normal. Depression. Okay. So we had the nurse is to maintain proper body. So we had musculoskeletal, cardiovascular, gastrointestinal, respiratory, urinary, skin, neurological. Okay, this is it's. I should know these. Okay, I should actually know these. Okay. Damn, I'm not even the first page. Jesus Christ. Okay. Or lateral, so rotating the hips from medially to lateral, or a lateral. The arm should be maintained in correct alignment with the shoulders and trunk and not allowed to fall inward. So the arm should be maintained in correct alignment. Correct alignment with the shoulders and the trunk. It should not be allowed to slump shoulder position, which causes the thorax to curve in an unnatural manner. Correct body alignment should be maintained. So slump shoulder position.
Causes
Okay. Correct body alignment should be maintained while the correct body alignment is maintained in supine position. In all various side lying positions, and even all sitting. So, body alignment in supine, side laying, and sitting. So we have supine, side, and sitting. When lying in the supine position, the patient's ankle should be flexed. So when lying supine, the patient's ankle should approximately be flexed approximately 90 degrees so that the toes are pointing toward the ceiling. This is referred to as dorsiflexion of the foot. If the toes are allowed to fall forward and the foot of the bed, the proper dorsiflexion of the ankle is lost and permanent plantar flexion of the foot conducts to a foot drop. So what does foot drop look like? Your foot literally drops. Okay. Your foot literally drops. That's like the best medical term ever.
So we have regular feet. Feet.
Foot drop. Okay. This condition is discussed further in this chapter. One common nursing measure to this combat the physiological effects is the use of range of motion exercises, which are a series of designs moved to each joint through its natural actions to decrease the level of muscle atrophy and contractures. It's necessary to maintain muscle mass and healthy bones. So we know that muscle atrophy is to decrease the incidence of muscle atrophy. So, the cause of muscle weakness, contractures, tightening of the tendons and tightenings of the tendons, and muscle mass, which is also muscle atrophy, and then healthy bones, which is less bone demineralization, which will stop the urinary tract from causing calcium. Also, the action prevents contractures and osteoporosis. So that's literally what I just said. Okay, so performing range of motion exercises every 8 hours to maintain. So range of motion exercises every 8 hours to maintain muscle and strength flexibility as well as joint flexibility. These may be active or passive exercises. Ensure that your support of extremity. Okay, ensure that you support the weight of extremities during range of motion. Ensure that you support the weight of extremities and joints during passive range of motion. Correctly apply support over therapeutic devices, maintaining proper body alignment, such as a trochanter roll, foot drop splint, and also follow the orders exactly. A roller roll is a rolled towel or cylindrical device placed snugly against the lateral aspect of the patient's thigh to prevent the rotation inward. So is a cylindrical device placed snugly against the lateral aspect of the patient's thigh. Let's see a trope roll. Electrochanterol. This looks nothing like I thought it would look like. Okay. Okay.
Inward. Some places have foot drop boots. Eugene.
Who else had a foot drop fruit? Rest in peace, John Miller. R.I.P. When he died, 2021. Yeah. R.I.P. to John Miller, man. Rest in peace to that guy.
They both used foot drops. Okay.
Okay. We fucked this page up.
Range of motion exercises use a variety of situations. They may be active or passive depending on who's moving.
Active are the person can do it by himself. Passive, the nurse has to help.
Look at that. I'm so smart. Active patient without physical nurse assistance are done with the nurse performing the exercise for the patient's joints.
Boom. Device that supports the foot in proper plantar flexion, suspends the heel over a small pocket of air, reduces the risk of pressure injuries and foot drop. Assist patients out of bed and ambulation assist patients out of bed with ambulation as soon as orders permit to limit the demoralization of bones. I don't know what this means. As soon as the orders permit to limit. Assist the patient out of bed with ambulation. So as soon as orders permit to limit the demineralization of bones. What a word soup. Assist the patient out of bed with ambulation as soon as orders permit to limit the who's ordering the demineralization of bones? The fuck kind of like instruction is this? Okay, effects of immobility on the cardiovascular. So we just talked all about musculoskeletal. Okay, we just talked about range of motion. Now we're gonna talk about cardiovascular. Heads. We should talk about that. We should read the skills. I'll maybe read the skills. No, I'm not gonna fucking the skills right now. Okay. But I am gonna do chapter 16. Take a break, and then we gotta read fit pharmacology. We have to fucking read pharmacology. No shot I'm not reading pharmacology by the end of today. God fucking damn. Why do I have all this work all of a sudden? Where did all this shit come from? Where did all this shit come from? I was literally just fucking chilling. this summer. God damn. Fuck. All right. Baby, I'm dreaming. Okay, bed rest can result in 50% reduction in blood flow to the legs. It contributes to venal stasis. Oh my god! We were just talking about that. Where is it? Which one was this? Was cardiovascular pooling of the blood? Chronic venous insufficiencies? Look at that. Right here, venous stasis. That's literally... Let me get this word in here. No. Chronic venous insufficiencies. Table. All right, venous stasis, or pooling of the blood in the veins. Pooling of the blood in the lower vein and legs. We got chronic venous insufficiencies, which is caused by venous stasis. Oh my god, I'm so smart. Venous stasis, which is a bed rest equals. Bed rest equals 50% of blood slowed. Okay, when a patient is lying down rather than sitting or standing, the heart works harder. So when a patient is lying down rather than sitting or standing, the heart has to work harder to pump blood throughout the body. This is because the muscle in legs. This is because the muscle in legs normally contract as you walk, sit, and stand, and helping return venous blood from the lower extremities to the heart. When those skeletal muscles are not in use, the heart must work harder to pump the blood through the body and increasing its workload. This also contributes to the factor of pooling in blood in legs, which can lead to blood clots. When the patient is confined to bed, he or she may develop a blood clot which may dislodge traveling through the vein. One type of blood clot is called deep vein thrombosis. Deep vein, I feel like I gotta know this word, deep vein thrombosis. Deep vein thrombosis. What is a blood clot? What is a blood clot made of? Blood clots are made of little cartilages called platework or meshwork protein. So, blood platelets, what are they for? Thrombocytes. So they prevent bleeding But so what's thrombosis? Thrombocytes. They're blood plates. So deep vein platelets. So platelets that are pooled. So when the person's in bed, develop a blood clot. A blood clot is just platelets. Okay, a blood clot. So what is a blood clot? So what is a blood clot? All right, what is a blood clot? Literally, what is a blood clot? Can someone literally explain like I'm 5? Not what is a blood? Okay, so we have, is it, okay. Dude, this is literally from my book. This is literally from my book. This is literally from my book. But he doesn't, okay, for example, if a patient remains immobile for too long period of time, I'm literally researching this topic. The blood travels in the veins and tends to get dislodged. Okay. So why did it pooled up, causing it to like clump together. That clumping gets dislodged in the blood. Okay. We know what a blood clot is. Pooling because of immobility. Pooling in the legs. Stagnant blood. Clumps. Dislodged. Okay, so one type of blood clot is called a deep vein thrombosis. Thrombosis is another word for plate. Okay. Which is a clot. This is a clot that develops in the deep veins of the legs. These type of clots can impair circulation in the limb. Other clots may develop more in the superficial veins of the legs and are less of a threat to lung circulation. Any stationary clot or clot fragment may dislodge either in circulation. And this is then referenced as an embolism. Embolus. Moving. blood clot
in the blood not moving, it's traveling.
All right. Any stationary clot or fragment made dislodge in circulation. This is referred to as an embolus. Okay, we had a traveling blood clot. The clot breaks away from the vein wall in the leg and travels through the bloodstream. As this embolus travels through the venous system, back to the heart and lungs into the arterial blood flow, there is a risk that it can be large in the small artery that supplies blood to vital organs such as the lungs, heart, and brain. Once embolus becomes large, so that it blocks blood flow to a portion of vital oxygen and preventing reaching the tissue, resulting in death, in the affected cells. When it occurs in the lungs, is referred to a pulmonary embolus. Oh shit! Look at me learning what heart attack and what is a pulmonary embolus though? How the fuck is that like the first word? Sudden shortness of symptoms. Okay. Pain can whole body, lightheadedness, low oxygen, fast heart rate, palpitations, dry cough, treatments. Okay, sudden shortness of breath.
So, pulmonary embolism. So we have a blood clot. We have a blood clot. So wait. So deep vein mean deep veins of the legs. DVT, deep vein thrombosis. Okay. We have, so the clot goes through the whole system, resulting in death of the affected tissue. Travels through the venous system back to the heart into the arterial blood flow. There's a risk that it will become lodged in the small artery capillaries that supplies blood to the vital organs, such as lungs and all that. Once embolus becomes lodged, so that it blocks a portion of the oxygen, vital organs that need the oxygen, resulting in death of the affected cells. So death of the affected cells. So you're feeling what? So when this is in the lungs, blood clot lungs equal this. Pulmonary embolism. When it happens in the heart, it is known as a myocardial infraction. Or heart attack. So we have a heart attack, we have a pulmonary embolus, blood clot. I thought a heart attack was when you're like your heart like literally stops beating. I mean that is a reason why the heart would stop breathing, but like it's a pump. So how does blocking when it happens in the brain? It's called a severe cerebrovascular accident, CVA, and commonly known as a stroke. An embolism in any of these three vital, so an embolism in these vital organs result in death. An embolism has been identified to be the most preventable. An embolism has been identified as the most preventable cause of death during hospitalization. The most preventable? So the most preventable cause of during death at a hospital is blood clots? What the fuck? Is this what they mean? No shot. We're going deep in the literature. There is a lot. There is a lot that is in here. It goes so you have to read these books so slowly to actually know, to know what the meaning of. I'm just reading over this shit. This shit is fucking crazy. Orthostatic hypotension, also known as postural hypotension, is the decrease in blood pressure that occurs. So what is all this? We have cardiovascular. So we have the musculoskeletal contractures, muscle atrophy, foot drop, body alignment. Musculoskeletal leads to urinary tract, we know that. Cardiovascular, we have blood clots. We have deep vein thrombosis. This is all just blood clots. So like a heart attack, blood clot. Pulmonary embolus, blood clot. So, it's a blood clot moving through the blood. See, that's the problem. There's some steps to this. There's the immobility. There's the pooling of the blood. And depending where, it would happen mostly in the legs, because the legs have muscles that contract a lot, and that moves blood up. So when blood is pooling in the legs, you're mostly going to get a blood clot in the legs, and then the blood clot in the legs gets dislodged. We have something called a embolus, right? So the deep vein thrombosis develops in the lane of the legs. So that can impair circulation of the leg in itself. And if it gets okay. We have some mattresses, we have these names and foot splints. Okay, we are learning. Orthostatic hypotension. Orthostatic hypotension, also known as postural hypotension, is the decrease in blood pressure that occurs when a patient changes from a reclining or flat position to upright position or standing, and is common after a patient has been in strict bed rest. Okay, so we have someone who's been laying in bed. So laying in bed for a long time. Yeah, someone lay in bed for a long time, and then we get him out of bed. What's the expectation? We have a decrease in blood pressure. So we have a person who's been laying in bed for a while. We get them out of bed. Their BP shoots down. That's called, what is ortho? Like orthopedic? What is an orthopedic? Why do I know the word but I don't know the word? Ortho meaning. Straight upright orthostatic? What do you mean orthostatic? Orthostatic? What is upright? We just looked at that. Okay, so we had hypotension. Okay, so we literally were just looking at this. So it's hypotension, low blood pressure, hypertension, high blood pressure. Okay, so we have
So we have the non-movement, the non-standing. When I think of orthostatic, I mean you're statically standing. Why does it all of a sudden mean you're laying down? Orthostatic. Traditional perception orthostatic, high blood pressure. Standing upright, blood pressure low, symptom equals symptoms high. Revised blood pressure is equal to or what does this mean? Not really one of the most unhelpful pictures I've ever seen in my life. Abstract. Symptoms recognition is impaired in patients with orthostatic hypertension. Roy Freeman et al. Failure to recognize symptoms of orthostatic may result in falls, syncopes, and injuries. So, this is what we got to know. Orthostatic hypertension. Orthostatic meaning standing upright. Static means, and then hypertension is low blood pressure. Okay, that's all we got to know. It's not that hard. Okay, and as a result of slow or inefficient vasoconstriction, as the patient becomes vertical, the blood in the as a result of slow or insufficient vasoconstriction, once the patient becomes vertical, blood pools in the lower extremities and abdomen, which result in the drop of breathing. Some people are dazed, pale, calming, and nauseated because the blood. To the heart. If the blood pressure falls too far, the patient may experience a sinoscope. And boy, knock the fuck out. If patient exhibits any of these signs while sitting, assist them to reclining position. Sinoscope. Sinoscope equals boy got knocked the fuck out. The patient is likely to experience orthostatic hypertension the first few times he or she gets a surgery. Most likely after surgery or any other procedure requiring bed rest for several hours. This is why it's extremely important for you to nurse. If any dizziness or sinoscope occurs, you will be there to prevent injury in patients. Okay. To prevent the formation of venous thrombosis, so we gotta prevent the development of clotting platelets, just platelets in general. So venous stasis, blood pooling in the lower extremity, not even in the lower extremities. To perform, it's important to keep blood from pooling in the legs where clots are most commonly formed. To do so, the guidelines encourage the extremities. If the patient is unable to do so, you encourage movement of extremities. If the patient is unable to do so, you'll perform passive range of motion exercises. Apply order devices to prevent pooling of blood in the legs. These include anti-embolism socks, anti-embolism stockings, tights. Oh no, we fucked up. Oh Lord. Which are sequential, which are air-filled sleeves that are wrapped around the patient's lower legs and connected to a pump that inflates and deflates
each sleeve is sequential. So we have sequential compression device. So like squeezy arms, I guess, you know. I'll call them squeezy arms. Equals SCDs, they inflate and deflate. To help increase the workload, so we need to help decrease the workload of, so how do we prevent blood clots? Range of motion exercises on the extremities, give them whatever devices, we just help decrease the workload of the heart to prevent orthostatic hypertension. Decrease the workload of the heart to prevent orthostatic hypertension. It's important to gradually move the patient. Gradually move the patient from lying to sitting. Encourage the movement of extremities, especially dorsiflexion and plantar of the feet, which will cause muscle contraction that will help push blood to the veins back to the heart. If the patient unable to move these, perform passive range of motion exercises, promote muscular pressure on the vein. That sets blood flow back to the heart. Change the patient's position. Frequently improve blood flow. If possible, change the position from elevate the head and move it as much as possible. Tell the patient she in the chair principle. Remain with the patient for a few times she gets out of bed. Follow principle. Okay. So we know how to stop cardiovascular. Respiratory. This is gonna be fun. So we have musculoskeletal, cardiovascular. And we got respiratory, the breathing. When the patient is unable to move about and take deep breaths, this results in the decreased lung. So when a patient is unable to move about and take deep breaths, this is a result of decreased lung expansion and respiration weakness, muscle pulmonary atrophy. We're talking about pulmonary atrophy. COPD, chronic orthostatic, no shot, chronic, what is it? Pulmonary, I know it's pulmonary disease, but what is the O in COPD? Obstructive. Okay. COPD. Chronic COPD. Chronic obstruct pulmonary disease. As a result, as individuals rest in bed, he or she tends to take shallow breaths. So when they're laying in the bed, they take shallow breaths that limit the expansion of lungs. Pneumonia or pulmonary emboli. How is a pulmonary? We literally just read that we have pulmonary embolus, the blood clot in the lungs. So pulmonary emboli or blood clots in the lung. Pulmonary emboli or blood clots in the lungs. Okay, but they didn't travel there. There's a difference. That's an embolism. That's when it reaches, though. But how does it get? So pneumonia and pulmonary embolus or blood clot. Okay, what is pneumonia? Okay, pneumonia is inflammation of alveolar sacs. That's pneumonia.
We have two different things. We have pulmonary embolus, blood clots in the lungs, and pneumonia are adverse respiratory conditions that can occur in immobilized patients. They are preventable, so it is extremely important for you to use appropriate nursing measures discussed in this chapter. Hypostatic pneumonia. So we have, I felt like I've Googled this 1,000 times. Hypostatic pneumonia. So what is hypostatic? What does hypostatic mean? I don't get what hypostatic means. The setting. No, I need to know hypostatic. Exhibiting a hypostatic. A heredity, depending. Bro, what does hypostatic mean? The settling of blood in our. So hypostasis. Okay, so hyperstatic is blood moving a lot, blood moving fast in the body. Is that what hypostatic means? Okay, hypostatic. So slow blood pneumonia? No fucking, that does not mean that. The settling of blood in a relatively lower parts of the organs due to impaired. What's hyperstatic? What's hyperstatic? You can't be hyperstatic. Hyperstatic. Give me, what does that mean? What does that mean? Because you can't say hyperstatic. Medical. There's no such thing as hyperstatic. Static means stop. Hypo means slow. What the fuck? Why would you say hypostatic? There's no such thing as hyperstatic. I have a gripe with these medical niggas, bro. Okay, so pneumonia is inflammation. So hypostatic pneumonia is a type of lung infection that occurs when the patient is immobile. So is a type of infection is a type of lung infection that occurs when a patient is immobile. So hypostatic means you're not moving. So hypostatic means you're not moving around. Secretions in the pool in the lungs, secretion pools in the lungs and the warm, dark, moist environment is ideal for bacterial growth, resulting in an infection. Healthcare association infections, once called non-communicable infections, are preventable in today's healthcare. Because such illnesses are preventable, some insurers are refusing to pay costs related to this. Was extremely important for you to be proactive. Okay, so these warm and dark environments. So we have inflammation of the lungs due to immobility. Inflammation of the lungs due to immobility. Prolonged causes bacterial growth. This is your fault. This is your fault. Okay. Now, so we know that. So we have hypostatic pneumonia. The person's hypostatic. Type of lung infection when the patient is immobile. Warm and dark environment is bacterial, resulting in an infection of the lungs. Healthcare associated infection. Acetalysis, the collapse of lung tissue affecting part of all of the lung can occur due to the inability of the lung to fully expand. It can expand, so it may occur when a patient. So it may also occur when a patient does not take a full deep breath to keep the alveoli open. When the alveoli collapse, oxygen and carbon dioxide exchange paired, resulting in lowered oxygen in blood, or hypoxemia. So oxemia is so it's hyperoxemia. Let's see if we get that word. Hyperoxemia. That's pressure. So below O2. To prevent prevent lung tissue collapse, and pneumonia, it is necessary to increase lung expansion and strengthen respiratory muscles and improve oxygen and carbon dioxide exchange, and improve the effectiveness of coughs. Use these actions to prevent respiratory secretions from pooling in the lungs. Oh fuck, my shoulder is so fucked. My shoulder is so fucked. What we got going on here? Am I not streaming in 1920 by 1080? Output video. 16, is it 16 by 9? Is Twitch stupid? Or is my fucking monitor shit? Really? You're dicking me down. I'm getting dicked down by this actual thing. No shot. Whatever. Alright, improve. Turn the patient every 2 hours to permit lung expansion. Elevate the head, so improve effectiveness from respiratory secretions, and turn the patient from one side every 2 hours to permit lung expansion. Okay, 2 equals lungs. Elevate the head of the bed 45 degrees or more to promote lung expansion. Encourage coughs and deep breath exercises every hour every hour? The fuck? Every hour? Are you serious? I'll do the coughs every hour. Encourage the patient to use incentive spirometer, taking 10 to 20 deep breaths every hour to expand lungs
to reach present levels of inspiration volume. An incentive monitor is a device used to encourage patients to take deep breaths because it provides visual feedback. The spirometer consists of 1 to 3 chambers, each containing a small ball. A platform the patient inhales and expels the lungs. The ball platforms in the chamber rises. The greater the volume that's in here, the higher the number of balls. Fucking gay. The greater the number of volume of air that is inhaled, the higher number of balls platform that rises, and the farther they raise. It's a little fucking mini game, huh? Little mini game. Guy is dying.
Guy's fucking dying. We're playing mini games here. Okay. Effects of immobility on the gastrointestinal system. When a patient is unable to be physically active, they may have decreased appetite. However, because they are healing from illness or injury, good nutrition intake is extremely important. See chapter 23. The major lack of immobility of the gastrointestinal system is the lack of peristalsis. What the fuck is peristalsis? Not fucking peristalsis. That's like the body's fucking shitter dumper. No, that's a series of wave-like muscle contractions that move food through the digestive tract. So we're talking about good nutrition's important. The major immobility is the lack. So the lack of waves or natural movement of tissues in the intestines. Okay. Movement of intestinal tissue. Okay. Again, without activity, the smooth muscles of the intestines are less active. This generally results in constipation, dudes flatulence, so dudes farting, distension, that's actually disgusting. It may cause indigestion and lack of appetite. So what, nigga, we got fiber here. This guy has to eat fiber. When peristalsis is slow, food moves slowly in the gastrointestinal tract, allowing the colon to absorb too much water. When too much water from the envelope, you have dry feces. Okay. So, effects of the gastrointestinal, so lack of appetite. Good nutrition is important. So lack of movement in the intestines that causes slower digestion. Which causes more shit to be absorbed. And we got dry shit. We got dry, hard shit. That sucks. Dry, hard, painful. Painful shit. That sucks. That's equal to immobility. So we got immobile patients taking hard shits. Okay. When peristalsis is slow, food moves slowly through the GI. We got it. Allowing colon. We got it. Dry heart. Okay, we got it. To help prevent constipation, intestinal gas, and lack of appetite, it is important that you encourage appropriate food and fluid intake. Muscle contraction and exercise helps stimulate paralysis. Making it important to ensure as much movement and physical activity is allowed, even when the patient is ordered to be on bed rest. Use these measures to help prevent gastrointestinal comfort for your patients. Okay. Where's my pen? Where's my pencil? Okay. 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 What am I looking for? What the fuck am I looking for? As soon as a healthcare providers assist the patient to get in a chair. So as soon as the health court assist the patient to get up in a chair or ambulate at least 3 or 4 times daily. Okay, get up 3 to 4 times a day. When a patient is on bed rest, ensure that the patient repositions at least every 2 hours and encourage active range of motion exercises. Provide range of motion exercises at least 8. So ROM equals 8 hours. Okay. The patient, place the patient in the sitting position to defecate on the bedpan or bedside commode, allowing gravity to assist in the elimination process. So help the boy shit. Okay, I got it. Help the guy shit. Inquire about the patient's foods, likes and dislikes. Help the patient select well-balanced, nutritious meals from the menu. Encourage the patient to choose foods with fiber to help the prevention of constipation. Include fresh vegetables and fruits to add fiber. Nice. Encourage fluid intake of 8 ounces every 2 hours. So 8OZ equals 2HR. Instruct the patient to avoid drinking fluids. Instruct the patient to avoid drinking fluids through straws if intestinal gas is a problem. Each time the patient swallows a sip of fluid, instruct the patient to avoid drinking fluids through a straw. Each time the patient swallows a sip of fluid, he or she also swallows a straw full of air? Straw full of air? No shot. No shot. That is not true. Assess and document the level of activity of bowel movements, sounds, and the frequency and characteristics of bowel movements. So, the shit chart. If the patient has not have a bowel movement in 3 days, laxatives. If there is no order, obtain order. The exception in the situation is when the patient's normal elimination route at home is less. Okay, the exception to this situation is when the patient's normal elimination route at home is less frequent than every 3 days. Okay. Provide laxative or stool softener. Okay. Oh, my fucking shoulder hurts like dick. Holy shit. I got a dicked shoulder, guys. I got a fucking dicked shoulder. And my camera sucks. Why is my camera doing that? What is the fucking, like... I don't know how to fix that. I really gotta learn how to fix that shit. Maybe it's not plugged into my monitor, my computer. Maybe I need to plug it into my computer. Fuck it. I don't care. What we got going? Provide stool softener. Okay. Laxative, stool softener. health care provider's orders. Okay. Now the urinary. Effects on immobility on the urinary. I'm a fucking idiot. The patient who is lying or is at bed risk is at risk for urinary tract infection because urine can pool in several renal pelvises of the kidney. Normally when a person is upright, urine moves from the renal pelvis into the ureters and then to the bladder. Bed rest interferes with this normal movement of urine. In addition, the patient is at risk for developing kidney stones, renal calculi because of excess calcium in the blood filtered out by the kidneys. Okay, when a patient, so we have two things. We got infections and we have kidney stones. So this is all urinary infection. Urinary infection. And then we have kidney stones. Kidney stones. I'll put your KS. Okay, when a patient must void. That's why they add so many stupid words. Voids. Okay, piss. When a patient must void on a bedpan or urinal while remaining on bed, he or she is less likely to completely. So they're less likely to completely empty the bladder. Bed equals bladder not all the way empty. Resulting in urinary retention. This retention provides an excellent medium for bacteria to proliferate, possibly causing a bladder infection that can spread to the remaining urinary tract. Okay, but if urine has a high pH, how does bacteria grow? Whatever. Okay, to avoid urinary stasis, prevent urinary. So urinary stasis. What is urinary stasis? Urinary stasis. Loss of ureteral tone combined and increased urinary tract lubricant, which leads to dilation of the ureters, renal pelvis, and calculi. Urinary stasis in the presence of vesicular reflux, predisposed some women to upper urinary tract infections and acute. Oh my god, they don't make it any easier to understand. Okay, avoiding urinary stasis. So I guess stasis. Static urine. Okay, urinary stasis, static urine pathology. It's like easier to think of. To avoid static urinary pathology and prevent urinary tract infection and urinary calculi, kidney stones, provide adequate intake to prevent concentrated urine. So fluid intake to prevent concentrated urine. Offer beverages. 8 ounces every 2 hours unless he or she has fluid restriction. Assist the patient to urinate in a sitting position to encourage full emptying of the urinary bladder. Male patients may be able to urinate best if they are allowed to stand. Male patients may be able to urinate best if they're allowed to stand at bedside. Be sure to obtain healthcare providers to be allowing this activity. So get permission. Get permission before let him piss over the bed. Damn. Reading for a fat minute. About to go fucking crazy. What we got going? What we got going? What we got going? What we got going? Damn. Evil Empire. Ugh, fuck, this sucks. This sucks so much dick. Let's get it. But it's okay. We got beds. We're gonna have the psychological effects. We're gonna have the positioning patients. Read a little bit more about positioning, and then we're done chapter 16. We can go to 17. Okay. So we have urinary, gastric, respiratory, cardiovascular, muscular. Muscular, cardiovascular, respiratory, gastric, urinary. Now we're coming to skin. Okay. So get permission for letting him before he pisses on your fucking face. Assess the patient's output. He or she void at least every hours. He or she should at least void at least every 8 hours. If the patient, he or she is properly hydrated, is unable to void, he or she may be catheterized to drain the bladder. Anatomy and physiology connection. Okay, so I hate this part. Okay, when a patient is immobile, many systems are affected. Often the changes in one system will affect another system in a negative way. So yin-yang balance. So we have one system will affect another system, other systems. In a negative way. We call those negative feedback loop. Negative feedback loop. Negative feedback loop. This impacts, so an example is the skeletal system is affected. This impacts the urinary system as well. A result of immobility, the skeletal system no longer needs to support the body for activity or weight bearing, which is what keeps the bone strong. Because of this negative feedback, the brain allows calcium. So the brain allows calcium, a mineral needed for bone strength, to leave the bones in larger amounts than usual. The calcium then enters the bloodstream, causing the blood to have higher amounts of calcium than normal. This is called hypercalcemia. Mia just means blood in general, right? Let me get this. Mia. Not MIA. Mia medical term, which means blood. No shot. MIA syndrome is substance of a blood. Substance in blood. So hypoxemia is low blood in your low oxygen in your blood. Hyperexemia is high blood oxygen. Hypercalcemia is just more calcium in the blood. Okay, hypercalcemia, we got it. The excess calcium circulating in the blood goes to the kidneys, where it's normally filtered out in the urine. If there's too much calcium present for the kidneys to effectively remove, the calcium collects. So if the kidneys to remove it, the calcium collects, forming one or more kidney stones
One salt called a renal calculi, and one salt called renal calculi. The lack of calcium in the bones leaves the bones prone, porous, and brittle. This condition is called osteoporosis.
So let's actually know what osteo means. Osteo means bones. Porosis. Bro, can you just break down the word for me? Porous bones.
People with osteoporosis can have bone fractures without any injury or trauma. Their bones may break and move. The spine may collapse, causing compression fractures, which are extremely infectious. So,
Compression fracture. So you're the vertebra. So the vertebral
gets compressed, and the apex pressure of compression causes a crack or fracture in the bone.
Okay, so we got effects of immobility on the skin.
When a patient is immobile and consistent pressure is applied to the same area of the body, the blood flow to that area is reduced or stopped entirely.
So we have pressure. We have a pressure gradient.
An immobile patient, when a patient is immobile and constant pressure is applied to the same area of the body, the blood flow of that area is reduced or stopped entirely. We have resistance. We have pressure in the form of immobility. So we have pressure in the form of immobility on a portion. The pressure is acting as a gradient for the blood. Okay, so blood can't move. Okay. When this occurs, the skin or underlying tissue die. This is referred to as a pressure injury. So pressure injury, we have a pressure injury. Okay. This is also called skin breakdown, pressure injury. Which is also called skin breakdown or decubitus ulcer. Decubitus ulcer. Okay. Decubitus ulcer.
What's decubitus mean? So the cubital skin, right? It's probably about scubital. Decubitus. The posture adopted by a person laying down. What? Decubitus. What is a decubitus injury? Bed sore ulcer. Okay, that's just the name of it. Decubitus ulcer. Bed sore images. Oh, I know exactly what these are. That's so unfortunate. Yeah, it's a bunch of butt stuff though. Hopefully I don't get. Okay.
The skin, okay, so this pressure injury, the skin may be red at first, but the skin will continue to deteriorate if the circulation in the area does not improve. Shearing of the skin Shearing of the skin will further destroy the integument. Shearing occurs when the skin layer is pulled across the muscle and bone in one direction while the skin slides over the surface, such as a bed sheet in the opposite direction. This shearing and friction on the skin can cause abrasions in open areas. Okay. So shearing. So bones, muscle this way, the skin goes this way, equals friction equals shearing. Patients on prolonged bed rest are especially at risk for developing pressure injuries. Special support surfaces and specialty beds have been developed to alleviate risks such as air fluidized beds, low air loss beds, and combination beds. It can be difficult to turn patients with multiple trauma and musculoskeletal conditions. As a result, some beds have been developed to turn from side to side. Some beds have been developed to turn side to side. And patients have less chance of developing respiration and cardiovascular complications while on bed rest. Okay. Let's get this money. What we got? Okay, so let me send populate. Okay, I gotta set. Ew, don't look at that. My courses. I wasn't able to. Okay, she didn't tell us where to submit it. Okay, so she's a dumb bitch. Let me see this. Okay, fuck it. We're back to reading. Fuck it. Alright. Nursing measures to provide adequate nutrition because tissue cannot repair itself without proper nutrients. Reposition beds every 2 hours, and those in wheelchairs. Okay, those in wheelchairs every hour if then unable to turn or shift their own weight. So reposition every 2 hours. Inspect bony prominence and redness every 2 hours. If you find area, if you area massage around them, but not on areas themselves. Information about use mild soaps for cleaning on the skin, followed by gentle but thorough drying to help maintain skin integrity. Provide an appropriate service for the patient, such as a mattress overlay and specialized mattress or specialty bed. Okay, effects on the neuroskeletal system. When a patient is immobile, several neurological complications may result. The patient may become less mentally alert and their visions may be less clear. Balance and coordination will decrease as, the patient may be less mentally alert and their vision may be less clear. Balance and coordination will decrease as immobility persists. So balance and coordination will decrease as immobility increases. In addition, the patient is not turned properly If the patient's not turned and positioned appropriately, the nerves may be compressed between the bone and the surfaces, and resulting impaired nerve function called muscle compression neuropathy. My favorite word. Compression neuropathy. Neuropathy meaning compressed nerve pathology. The most common site for compression neuropathy is the lower extremities. The most common for compression neuropathy is the lower extremities of the immobile patient. Is the personal nerve at the fibular head. So the proneal of the patient nerve is the proneal nerve at the fibular head. So where is that nerve at? Proneal. What the fuck is the word? Proneal nerve. This is the foot drop nerve, right? This is literally the foot drop. It's literally gonna be under your heel. It's literally gonna be, I know exactly where this nerve is. Fibular head. Images. Oh, I'm totally fucking wrong. Subcutaneous proneal, superficial cutaneous branch. So the tibial nerve, fibular head. Where's the fibular head? Deep proneal nail. So it's right here. Superficial proneal nail. Static nerve. Bro, why are there nerves? Why are there so many fucking nerves? Common proneal nerve right here. Where's the head of the fibular? You have your fibula, you have your tibula, the head right here. Where is this bitch? Fibular. Where is the fibular head? Bro. Your fibular head's right here. Common nerve. Common proneal nerve. Okay, I know exactly where this is. So compression of this nerve can result in foot drop. So you have your tibula, your fibula, you have a nerve right here. This is the nerve that equals foot drop. I'm glad I know which nerve helps with foot drop, because this condition can be permanent and will prevent the patient from able to walk normally, able to talk normally for me when she's used to ambulate. Foot drop may also cause injury, paralysis, and weakness of the muscle and nerves of the foot. I hate reading. To prevent adverse effects of immobility on the neurological system, it is important to take measurements to maintain alertness, visual acuity, and To prevent adverse infections of immobility on the neurological system, it is important to maintain alertness, visual acuity, balance. Use these measures to promote neurological function. Determine a patient's level of conscious by asking specific questions related to the person, place, and time. Use a foot splint or a high-top tennis shoe to keep the patient's feet in natural position. The ability to perform neurological checks to determine the changes in the patient's neurological status. See how it says the neurological condition. Provide cues to correct date and time in the room. Keep a calendar and clock within the patient's line of vision. Open curtains to allow patient to observe weather and season. So open curtains. If the person is confused about time and place or person, gently reorient them by supplying him the correct information. Boy, this boy confused as fuck. This boy just confused as fuck these days. People just be confused. Alright. Support and specialty surfaces. We have a mattress overlay. It's like an egg crate mattress. So some egg crate mattress. That's okay. Yeah. Apply to the top of mattresses may be filled with air made with foam. Mattress overlays. So these are how many we have? 1, 2, 3. So we have specialty support surfaces. So we have beds and surfaces. Yeah, two supports. 2 supports. And then 3 specialty beds. Two supports, 3 specialty beds. Okay. Yeah. Egg crate mattress. We have specialized mattress. We have mattress overlay, specialized mattress. Mattress containing special memory foam chambers, including air. So this is just something on top of the bed. Mattress overlays. Specialty beds. Air fluidized beds. An encased mattress filled with small round beads coated in silicone to prevent clumping. Air is pumped through the bed, which causes the bed to mimic liquid. Patients rest a thin sheet within the air fluidized compartment. Combination low air, low loss, lateral rotation bed. What the fuck kind of word is this? Combination low air loss and lateral rotational bed. A combination of bed that is low air loss type of bed with lateral rotation to prevent pressure on one area. Each pocket is filled with air and can be inflated, deflated. Can be utilized with a ventilated assisted patient. Okay, continuous lateral rotation bed. Special type of bed frame that allows the entire bed to turn from one side to side. Mattress is low air loss. Bed can be programmed to turn by degrees at set intervals. Okay, so we got like an egg crate mattress. We have okay, let's break it down. We have support, and then we have specialty. Support surfaces. And then we have specialty beds. We got the support surfaces. We got like a egg crate mattress. Okay, we have under support surfaces we have mattress overlays, and we have specialized mattresses. There's no machine. Specialized there is machines, but they don't move the bed. Mattresses. Specialty beds. We have air fluidized bed. We have a combo C L A L R beds. We have combination low air loss lateral rotation bed, and then we have CLR beds. Okay, we got all those beds. We have 5. What the fuck? I hate the medical. I hate fucking. Why did I ever think of it? Okay. Whew, I need to get some water, actually. I need some water, me. Whew. Get a fucking water bottle. God damn. Let me open the window.
Fuck. Oh, and whoever's watching, there's someone watching. You are a boss. Whoever's watching, thank you for watching this shit. Actually, yeah, thank you for watching. You can do whatever. Okay, I'm getting some food warmed up. Let me eat some yogurt. It's only chapter 16. Okay. 17 soon. Damn. Okay. Let's into that, and then we'll do 21. And then tomorrow I'll do the 4. Okay. Whew. Damn. Oh, that doesn't sound good. I'm tired. Okay, let's. For example, if the patient thinks it's Tuesday, you might say today. If it's Tuesday, you might say today's Thursday. You have been here for 2 days. Now, to help
the patient vary in time. Psychological effects of immobility. Psychological effects of immobility will differ with each individual. Psychological effects of immobility will differ with individual. Depression, anxiety, hostility, fear are common adverse effects of immobility. Restricted mobility affects the patient's self-image, independence, ability to meet his or her own needs. If a person has always taken care of himself and now must rely on others for simple activities such as washing his face, in addition, here may also be concerned about finances, work, and family issues. No kidding. He or she may feel rejected or forgotten because others do not come visit as often as desired. Aw. Sensory deprivation may also occur if a patient must lie on. So sensory deprivation may occur when a patient must lie in bed all day, all night, especially if the patient is alone in a room. With decreased sensory stimulation, the patients may increase hallucinations. So we have just there's like tons of things. So we have there's a lot of things. So we have restriction of mobility. So we have like we have there's actually so many things to think of. Okay, they're all negative. All aspects are negative. That's all I'm gonna say. All aspects of daily life become negative due to expectations of one's self. Boom. Alright, so with decreased sensory stimuli, the patient may experience audible or visual hallucinations. Keep in mind, bro. If my fucking computer's waterly actually is bad, keep in mind. If that's what I'm hearing, that's not good. Okay, if the patient, it is possible that the patient will have difficulty sleeping when they're unable to get out of bed and be active. They may become restless and irritable. So, sleep deprivation. And may take out their frustrations. They may take their frustrations out on you. Should this occur, do not take any as personal. Not personal. Empathize with his or her feelings. When your nursing skills, find a way to occupy time and help patients find a way to occupy time and sleep better. Nursing measurements to prevent physiological. All right, we'll finish the chat. Look at my food. No, 5 second roll. 5 second roll. Nobody saw that. I don't give a shit. Oh my fucking god.
Studying while eating is probably a good idea. Okay. What we got? We have a bunch of new information. Oh my god. Okay, so what is there? What is there? Okay, good. Let's read. So, to help prevent depression, anxiety, fear, and to promote self-worth, use these emerge. Minimize sensory deprivation by ensuring the patient has distractions to keep himself occupied, keep the brain moving. These include television, radio, magazines, newspaper. Man, put gaming in there. Gaming. Sick people just need to play video games. Bro, sick people need to play Modern Warfare. Sick people should play. Oh my god, what if they have a cracked ass kid? What if there's some terminally sick cracked ass Warzone player? Dude has stage 9 fucking lung cancer, but it's mean on the keyboard. Alright, I'm gonna stop. That's horrible. When you're with a patient, try to involve his or her senses with pleasant smells, tastes, or sights. So increase serotonin, increase serotonergic activities and sensations. Help the patient improve sleep pattern by encouraging him or her to remain awake most of the day. Keep windows or curtains and blinds open in the daytime to allow natural light in the room. Natural light cycles. Encourage and allow the patient to do as much as possible for him or herself during patient care, such as helping with their bath and performing range of motion exercises when they're able to, and making decisions. Let them do things they can. Allow the patient to express concerns. Encourage the patient to talk. Venting is therapeutic. Take steps to involve other professionals such as social workers, pastoral care, or home health care if appropriate. Encourage visits. Try to schedule care around visitors. Try to schedule patient care around visitors if the patient has few guests. Allow visitors to participate in care if they wish to. So, ain't nobody wants to not washing. I mean, what can the okay, whatever. All right, so we have just finished. That is a chunk. We have a chunk of chapter 16 done, which is the pathologies of immobility. Holy fucking shit. We're on to a new era, boys. We are on to patient positioning. When a patient is unable to move, so this is like every 2 hours apparently. ROM every 8 hours. 8 ounces every 2 hours. Okay, we actually have some knowledge here, boys. We have some knowledge. When a patient is unable to move independently, you will need to provide assistance in position changes to prevent complications associated with immobility. We're talking about pathologies of immobility. Traditionally, the gold standard of frequency position changes immobility patients have been every 2 hours, although some patients need repositions more frequently. 2 hours unless more is needed per individual. More/less is needed per individualized case. Assisting with patient positions. It's important to maintain good body mechanics when positioning patients to prevent injury to patient and staff. See Chapter 13, Mechanic. Safety. For safety patient handling, always lock the wheels of equipment. Elevate the bed to a comfortable working height. After patient care, place the bed in the lowest setting with the wheels locked to prevent possible injury when the patient gets out of bed. So, wheels locked. Elevate for your back. Set to lowest. Lock the fucking wheels. Lock the fucking wheels, okay? Lock the fucking wheels. Holy shit. As a general rule, patients who need assistance with positioning will need position change. So, patients who need assistance for positioning will need to be positioned at least every 2 hours when on bed rest. If the patient is confined to a wheelchair and cannot shift position independently, you will need to adjust his or her position in the wheelchair every hour. So, wheelchairs, repo per hour. Patients who are at risk for skin breakdown. At risk for skin breakdown may need even more frequent. So, bad skin equals repo increase. This includes patient with thin, dehydrated, malnourished, or immobile. In most situations, you will position all extremities so that they will maintain their function and flexibility. Oh, fuck. Okay. The term position of function means placing extremities in alignment to maintain the term position of function means placing the extremities in alignment to maintain the potential for their use of movement. What a fucking... I hate this word soup. I literally have to sit here and play their little game of what does this mean. Like, what does it actually mean? So I don't fucking think of it as a wrong thing. Oh yeah, you should know what that means. It's English. You should know what it means. It speaks English. Position of function medical definition. Images. It's just, Jesus, it just means like positions. Okay, so just typical, so position of function means placing the extremities in alignment to maintain the potential for their use and movement. Positioning function will help and prevent undue pressure on nerves and to help discomfort, pain, and nerve damage. Many simple positioning devices are able to maintain good alignment and prevent excessive pressure on joints and nerves. Positioning devices include so we have positions of function, which means a position that has a function. Okay, so position, body alignment, and it has a function. So so if I say supine, it's laying on your back, and what's the function? I mean, it's the hardest for your lungs to breathe, right? So lying on the back, purpose for physical navigation, resting. Okay. Position of function of medical use. Okay. Many simple positioning devices are available to help good alignment and prevent excessive pressure on joints. Positioning devices include pillows, hands, rolls, arm boards, foot splints. When you're placing a patient extremities in this position of function, avoid direct pressure over bony prominences, compromised tissue, and pressure injuries. You may need to use additional padding on positioning devices to prevent pressure. You may need to use additional padding on positional device to, so we're just going to call it a PD, positional device, equals positioning device used to aid position. Okay, positioning. Patient teaching connection. Explaining to promote cooperation. Oh my god, these guys. Explaining to promote cooperation. When you care for a patient who has mobility problems, always make it a point to explain what you will be doing for the patient. Many patients who require positioning assistance may be sedated from a surgery or have decreased levels of understanding because CVA, which is a stroke, CVA, cerebral. Let me see the real word for it. What's the real word for it? I had it written down. It's literally cerebral vascular accident. Stroke. Cerebral I was about to say vertebral. I was like, that's not right. Vascular accident. Okay. And that's because of an embolism, which is embolism is blood clots and whatever gets dislodged into. Okay. A decreased level of understanding because of a stroke, aka stroke. Just all this, aka stroke. AKA stroke. Head injury or dementia. Head injury or dementia. When you give instructions, head injury or dementia. When you give instructions on how the patient can help with position, can be sure those instructions are appropriate level of understanding for the patient. The patient will be more cooperative and less likely to resist during repositioning when he or she understands what is to be done. Important to remember that no matter how well a patient is positioned, it is necessary to reposition every
2 hours, and possible more frequently if the patient is unable to move himself.
Okay, so explain. Just means explain equals cooperation, which equals better outcome equals remember every 2 hours. Explain equals cooperation equals better outcome. Remember every 2 hours. Okay. Selecting appropriate positioning devices. Yo, I need some fuel. I need some fucking cheap yogurt. Cheap ass yogurt. I need cheap yogurt to eat. I like peach, but I'm broke and all I have is strawberry. I actually fucking love yogurt. Oh my god. Medicine. I have to learn about medicine. I have to learn about doing this shit right, guys. Damn, can I listen to some music at least? They get so gay. Excuse me. They get so mad when there's copyrighted music. Oh my god, this shit's been on this whole time. Excuse me. Let's just take a little. I'm gonna come back to this, but let me just eat some food and watch some Leo for a second. Actually, we're not gonna watch any Leo. We're gonna just chill out. Gonna eat some food. Today's just gonna be a really simple day. We're just gonna research. We're just gonna research all day. Got a workout in this morning. I'll get a workout in later tonight and get some sleep. I got a call tomorrow with some students that I work with. They're not students of mine. I'm a student too with them. We're all students. And we're going to have to pick up because we are behind. I am so behind. I'm talking to myself. I'm talking to the behind, but it's all good. Dr. Gates made a good record. She was like, "You gotta get through me." I gotta get through Dr. Gates before I can hit this shit. That's crazy. She thinks she's so funny. Guess what? I'm after your ass, bruh. It's a piece of cake. I'm so fucking ready. This shit's a piece of cake. This shit is such a piece of cake. It's gonna be hard, but it's that easy. But first, let me get a jetty. I need a jetty. It's that time. I need a jetty. All right. Selecting appropriate positions and positioning. In many situations, you will decide which position to use for procedures. In many situations, you will decide which position to use for procedures to promote comfort for patients. Specific positions are used for specific purposes. A common patient position to describe each and list the purpose in which they use. When you position a patient, it is important for you to support the limbs. So when you position a patient, it's important for you that you support the limbs in the areas of the body not in contact with the bed. So support the limbs in the area of the body that are not in contact. You will accomplish this by using pillows and other positioning devices. The placement of these devices is discussed in skills. Okay. The table describes commonly used positioning devices, their purposes, and their placement. Okay. Alright, so we have this should be so how many positions? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 14 positions. 2 sims. 2 sims. 2 sims. 2 tren. 2 sims. 2 tren. 4 fowlers. Okay. 2 sims, 2 trends, and 4 fowlers. So we have supine. We'll name that number 1. Dorson recombinant 2. Trendelberg 3. Reverse Trendelberg 4. Lateral 5. Left sims 6. Right sims 7. Fowlers 8. Low fowlers 9. Semi fowlers 10. High fowlers 11. Orthopedic 12, prone 13, lithotomy 14. Okay, bad. Supine position. Lying on, I know what supine is. Lying on the back with arms aside. 4. So it has physical assessment, resting in bed, undergoing anesthesia. So we have physical exam, resting, anesthesia, so supine has 3 purposes. Dorsal reincumbent. Let me see these fucking pictures, bro. And let me get some fucking music going. I need to hear something. No, I don't. I want to listen to copyrighted music so fucking bad. We'll just. All right. Dorsal reincumbent. Knees up and backward. Lying on back. So we have someone laying on their back. We have supine. Laying on back with arms at side. Dorsal. Oh, this is like. These pictures are so crude. Lying back with arms at side, legs apart, knees bent, feet flat for physical examination of abdomen and genitalia. So dorsal reincumbent. Just think of pregnant. What are these pictures? Sorry, guys. I don't mean to show these to you guys. What the fuck? Okay, trends and trying to work. Freaking a CIA treatment. CIA treatment. I'll just call it fucking CIA treatment. Lying on back and arms aside, bed position so far is higher than the during. Okay, purposes, 3 purposes. 3 purposes. During some abdominal surgeries. So for abdominal surgeries and shifting abdomen contents upward. To shift abdomen contents upward. So you have upward trend. Abdominal surgeries. Okay. Physical examination of abdomen and genitalia. Penial care. Examination during labor. Just think of dorsal reincumbent supine, resting in bed, undergoing anesthesia. Reverse Trendenberg, lying on back with arms at side, bed position so head is higher than the foot with no foot flexion at the waist. After, okay, so we got, let's get the reverse. Angiograph procedures. What the hell is angio? Angio is like your brain. Angiograph. Angiograph. No, I'm so fucking stupid. It's your heart. I'm so stupid. What is angiography? X-ray of blood. Oh, so what is angio? Angio means blood, right? So angio means vessel or container. So that's blood. That's why blood's always bringing stuff. Okay. So angiogram is like visual angiographs or like visualizing. All right. That's it. It's after angiography, like blood vessel imagery. Procedures allows the head to be elevated without causing pressure on the femoral artery. During some abdominal surgeries and shift abdominal contents downward. So, trend is upward, reverse is downward, upward trend. So downward is reverse. Shift abdomen contents downward equals reverse trend because you're shifting it down. Okay. Lateral. Lying on the left or right side supported by the back and ankles and knees with pillow and good body alignment. So they using with pillows and good body alignment. So we have our first PD. We're using our first PD. For patient comfort and to promote lung and cardiac function. So this has we have blood, so we have respiratory and cardiac. So circulatory and respiratory. Okay, relieves pressure on bony prominence of the skin and sacrum. That also is skin integument and bone muscular skeletal, which is so lateral is good for literally circulatory, respiratory, your skin, cardio, muscular skeletal, and psychological, because it feels good, comfort, and urinary because is a second order effect. Second order, we'll call it a second order. Okay, so lateral is pretty fucking sick. Okay, but we don't even need it. Lateral just means side, so let me draw the picture of the guy on the side. Let me see this. Let's see the pictures though. Okay, we have dorsal recum. Okay. Can we get to the ones we need? Okay, so pillows supported behind the back. I don't see a pillow behind her back. Bullshit. So lying on left or right, supported behind back and between knees and ankles with a good body alignment. Left sims. Let's see left sims. Is your better not get left sims right. Left sims. The fuck is this bullshit? Okay, lying on left side. So lying on left side, semi-prone position with right leg fixed, drawn towards chest. Left arm is positioned along back. Left sims. What does it say? Left arm positioned left arm back. For rectal examinations.
Administering enemas. Left Sims, left arm, back booty. Right Sims. Lying on right side and semi-prone with leg left, fixed right arm position along patient's back. Right arm back. That's booty. This is bony. Because this relieves pressure. Left Sims for booty. Right Sims for bony. There is a difference for bony. We got Fowler. You always love Fowler. Semi-positioning.
Let me see this shit. I hate positions. Where's Fowler? Okay, so we know. Let's visualize. Let's visualize. Supine, laying back. Dorsal reincumbent. Labor. Trendelenburg, CIA treatment. CIA treatment. And not for angiograms. No, that's for surgeries and shift. Okay. Reverse Trendelenburg. Lift. So if this is CIA, this is reverse. So we can let abdomen surge stuff down. Angiographs, surgeries and stuff like that. Okay. Lateral on your side. What is just only what is lateral? Patient comfort? Yeah, it's literally all of the immobility. Lateral is just to solve all the immobility pathologies. Lateral immobility pathologies. Immobility pathologies. Literally comfort. That's crazy. Left Sims, just straight up booty. Right Sims, bony. So relieves what? Relieves pressure on bony prominences of coxae and sacrum, just pelvis. So bony pelvis. And we're actually using PDs, we're using positioning devices, okay? Fowler's semi-sitting with various degrees of head elevation with knee slightly elevated. Let me see Fowler's. Knee chest. Oh my god. I need more Fowlers. Fowlers. Oh, let me draw the picture for left Sims. So we have like his left arm is gonna be at this dude's back, and his right arm is gonna be up front, and his legs are gonna be. Wait, let me see. We have Fowler's, and then let me see. Left Sims. Okay, and then legs over. Wait, no, I need left Sims. Where's left Sims? Sims. Okay, wait. Knee. Okay. Left Sims. Right leg flexed, drawn upward. That's your fucking left arm. So this is left Sims. This nigga's left arm. His left arm lying on his left side, semi-prone with right leg. So this is my right leg. Flexed, drawn up to chest. Left arm is positioned along with patient's back. He's laying on his chest, prone, with his right leg. Holy shit. Left arm. So you're literally laying like this. Well, what is your right arm doing? Is it flat? Like what is... Wait, but if this is my right leg, I'm laying prone. left arm along the back. Bro, what the fuck? That's not, what is this? This left arm and leg is being pushed down. That shit don't make any fucking sense. Let me see. Left, that's his right arm and right, okay. I'm overthinking, I'm really overthinking this. Okay. Left leg, whatever. So all we gotta know is left arm on the back. Okay, whatever. I don't know how it's like gonna be. Fowler's base purpose is based on elevation. Fowler's purposes based on elevation. Multi-purpose degree based. Multi-purpose degree based. Multi-purpose degree based. Okay. Head elevated 30 degrees. Okay, let me draw. I tried drawing this shit, but I guess it's fucking stupid. Oh, bet. This is literally it. I found it. His leg is like this. Look at that. Right. Okay, that's your right arm. He's laying semi-prone, leg left. And yeah, it's literally, yeah, I know exactly what this is. These are not Sims. Left Sims position. Yeah, bullshit. There we go. This is perfect. Yeah. Left arm back, right leg flexed. Okay, perfect. That's exactly what I'm looking for. Those other pictures were stupid. 30 degrees. Prevent aspiration during tube feeding. Let me make sure I know what aspiration means. No, not your fucking shitty company. Is a personal finance company with over 300. What? What is interest rates 1%? 2013. Joe Sandberg. Can I just get like a regular net worth? President to fight poverty? Bro, you're making millions. Go fuck yourself. You stupid aspiration company. Action or process of drawing breath. So breathing in, tube feed, like Steven. Boy, always changing his bed height. Okay. Semi-Fowlers. Head of bed elevated 45 degrees. To comfortably watch TV or converse with visitors. Abdomen surgeries to alleviate tensions. Assist patient who have difficult breathing. So we have 30 degrees aspiration during feeding. 45 degrees. 45 has fun. Abdomen and respiration. So that's low Fowler, semi-Fowler, high Fowler, 90 degrees. Eat and drink without risk of choking. Assist patient difficulty breathing. So, choking, hazard, eating, and respiration. Oh, that yogurt did not sit right. Or maybe it's the caffeine. Orthopedic. What is ortho? What the fuck does ortho? Standing up? Pedic. Tempur-Pedic. Relieving? Is pedic mean relieving? Orthopedic, something relieving? Standing relieving? Or orthopedic? Is Abrantes surgery involved in the musculoskeletal? That makes sense.
Sitting upright with the bed elevated, not orthopedic. Sitting upright with head of a bed elevated at 90 degrees, so on the side of the bed with feet flat on the floor. Patient is leaning slightly forward with arm raised and elbows flexed to support over the bed with severe respiratory distress by allowing chest to expand to maximum capacity for moving air in and out the lungs.
Okay, so let's see. Orthopenic. Let's see with orthopenic. Why did I say pedic? So let me get these. Oh, I haven't even gotten these degrees. So guys down here, arms out, hands like this, leg like this, straight. Oh shit, dude, straight. Another guy, his arms like this, this, his knees up, his legs down. This guy, Fowler. Okay. Damn, I hate caffeine. It's like, what? I thought caffeine, it makes me focus, but I have a problem with it. Okay. Orthopedic. We have a guy just. His head's right here. Pillows needed. Respiratory distress. To improve oxygenation, patient with acute respiratory distress. Severe. Prone? Lying on the stomach with head turned to the side to improve oxygenation in patients with acute respiratory distress. So sitting, not shitting. I keep sitting. Sitting, school, table, sleep, chest expansion. That's orthopedic, orthopenic. Prone, improve oxygenation in patients with respiratory distress. Prone, O2 to rest.
pressure on back, cocks, and hips. It's for prone. Lithomy. Line on back with knees flexed above hips to support and supported hips. For vaginal explanations, delivery, neonate, pelvic, and gynecological surgery procedures. So lithotomy. So dorsal incumbent pregnancy. Fake pregnancy. Lithotomy position.
What the oh, okay. That is a, oh my god, that guy's actually having a kidney stone. Oh my, I should not have looked at this up. I should want to look up the position, not like what it looks like. I don't want to see it in like, no, it like, okay, legs above, that's what I needed. Oh my god.
Okay, so this is like dorsal reincumbent is like for female piss, like fake pregnant piss, like urinary. Lithotomy's actual pregnant delivery examination. Lithotomy. So we have lithotomy, examination, prone for like
extra oxygenation, pressure. So we have, okay, so lithotomy has one, okay. High Fowler's eating trink, semi Fowler's TV, it's at like 45, likes to have fun. Lower Fowler's 30 degrees, aspiration for tube feeding. Fowler's depends on the degree. Right Sims, right arm booty, so like rectal exams. Left Sims, right Sims is for bony. Left Sims, the left likes booty. Lateral immobility pathologies. Reverse Trendelenburg is just laying up. It's good for like angiogram pathologies. Trendelenburg is just the CIA method. What is it actually good for though? Shift contents upward. Okay, I guess I meant to. Okay, dorsal reincumbent. It's like for, but it's like it's a urinary like examination of genitalia. Okay, gynecology. Gyno surgery. I thought gyno for guys was like breast development. Okay, so we learned about the 14 positions. We have 2 Sims, we have 2 Trends, and we have 4 Fowlers. We have orthopenic, prone, lithotomy. Okay. You can make positioning and supporting devices out of common objects that may be available in home health, client care. These work as well as more expensive alternatives. Armboard can be substituted with balsa wood with foam, washing cloth padding on the armboard to increase comfort. Add wrist roll fashion like hand roll from washcloth folded in half. Place under patient's wrist to support. Blanket roll. To make a blanket roll, roll a small blanket into a firm roll. Use this to keep the patient lying. Hand roll. You can make this out of a hand roll by folding washcloth into half and then rolling to a log shape. Ends of these place prevent the unrolling of a hand roll. Use this to now prevent contractures of the fingers. Foot split is possible to provide. By placing a blanket roll at the end of the patient's feet, you can make a blanket roll by rolling a small blanket into a firm blanket. Okay. Damn, this yogurt, I need to drink some water. I need more water. Let's see this. I have to get a new one of these. It's broken.
You have 7 PDs. Pillow pads. So pillow was the head, knees, supine, knees, underneath and supine, between knee, lateral, back, no pillow for Fowlers or Sims? Where's the pillow? Hold on. Yeah, orthopedic needs one too. Orthopedic. Head. They totally forgot orthopedic. Bro, the book is wrong. The book is so wrong. Orthopedic. These niggas are stupid. Stupid. What the fuck are you thinking? Bozo. Rest in piss. How are you gonna forget about orthopedic? Armboard, wrist, blanket roll, feet, hand roll, palm, foot splint, soles of feet. What does it do? Armboard, prevent flexion of the joint such as when an IV catheter is near a joint. Restore elbow.
Wait, what the fuck?
What? Prevent function at the joint. Okay. Such as an IV catheter near the joint. What the fuck does this mean? What the fuck does this? Oh, IV catheter. Oh. Not only piss, idiot. Okay. Blanket roll used to support the back or soles of the feet. Place. So, blanket roll and foot splint used to maintain function of the feet in relation to the legs of a patient with decreased movement and strength, lower extremities. Support. Same, but people in worse position. So we have hand roll used to maintain position and function of the hands and fingers in patients, decreased movement of the hands and fingers, hand roll, stirrups, position for vaginal surgery, pelvic examination and delivery, and place feet in the stirrups in position of the lower legs, and the feet with the dorsal recumbent position, stirrups, lithotomy, dorsal recumbent. Leg, hip, suction. External rotation of the legs and hips at the lateral side of the hip and thigh. Prevent leg. No, it's not. It's leg hip suction. Okay, that makes more sense. Leg hip suction. Transfer roll. Makes more sense. Okay, so that was just all patient positioning. Oh my god, my book is literally molested. I've literally just molested these books. Okay. Molested's not a good word. Don't say that, Abby. Don't say that. I've interacted, okay? Molested. I'm a fucking idiot. Alright. Let's see this shit. Lifting. Oh, okay, so I have to read. I have more reading to do, though. I have so much more reading to do. Okay, we're gonna do 17. Probably is how much more 16? Okay, we have. Okay, this should be really simple. Okay, we'll get this done, and then we'll be done. Done. Yay.
Yay. Okay. So there it's 1.6. Scales 1.6 through 1.8. Scales 1.61 to 1.8. Okay, those are skills. Let me just highlight those. Okay. Okay, chapter 17 vital signs. We got I gotta review some of these things. Oh, this is gonna be lit. Okay. And then done. Yay. Skills 17.1 through 8. 17.8. Yay. Let's go to chapter 21. We got... Oh, Lord. Yeah, physical assessment. Okay, this is just the documentation. This is gonna be later than light then, I guess. Let's finish 16. I really gotta start reading farm. I wanna do 16. Okay, let's do 16. We're gonna do 17. We're gonna start farm. We'll get into nutrition and then running back, and then we'll run it back fundamentals. How many hours? How many hours in a read this bitch? It was 10 hours, 3 hours and 40 minutes, I guess. 37. Okay, not bad. We actually have some good pacing. Not bad pacing. So more documentation in the back. Done. Yay. 21.1 through 21.8. Okay. More documentation in the back. Okay. Let's just finish up chapter 16 now. Let's get this fucking shit out of the way. We've been on here for too long. We're supposed to learn all of this. I did not learn any of this shit. 7 positioning devices. 14 different positions. 5 different type of beds. Effects of immobility. Not a bad chapter. I thought this was gonna be worse. Whoa. I thought this would be way worse. Wow, like actually reading's kind of therapeutic. Alright, let's get to the last part. Moving and lifting. So we just did positioning, now moving and lifting. Enormous tasks required by the nursing staff.
is the handling and movement of patients. Enormous task required of nursing staff is the safe handling and movement of patients. Nursing has one of the highest rate of musculoskeletal injury rates in the work environment compared to other occupations, resulting in numerous lovers leaving the position. In addition, many of the nurses who remain in the position have left bedside nursing because of the physical demands of direct care. Researchers suspect that many musculoskeletal injuries occur to nursing staff are unreported. It is important for you to protect yourself from injury by using proper body mechanics and how to safely lift. Safe patient handling is of great concern, not only to nurses but also to their employees and also their professional organizations in the workplace today. There is a new emphasis on ways to replace manual lifting. Okay, so safe patient handling is one great concern to nurses, but also to their employers and professional organizations in the workplace. There is a new emphasis on ways to replace manual lifting with equipment designed to assist nursing staff. So we basically this just talks about just nursing and physical demands. Nursing and physical demands and muscular skeletal injuries. Muscular skeletal injuries. What is a gold standard? How can you prevent foot drop? How can I prevent foot drop? Let me read that. How can I prevent foot drop? Foot splint? Foot splint? Does a foot splint work? What is a foot splint? Cyanocope fainting. Foot drop literally drops foot drop boots, I guess. Foot drop boots. What is the gold standard for frequency patient of immobile every 2 hours? Two hours. Frequent repositioning of patient can prevent which complications? Fucking 7? 7 complications. What are the first thing a nurse should do after approaching a patient? What should the first approaching a patient prior to repositioning? Explain what you're gonna do. Okay. We talked about the positioning, safe patient handling is a great concern to not all this Nursing Association, ANA, Nurse and American Nursing Association has instituted the Handle with Care campaign. It is a response to significant numbers of musculoskeletal disorders reported by nurses. The purpose of this campaign is to build an industry-wide program in healthcare to prevent musculoskeletal injuries. So damn, I can't write anywhere in these margins. These margins are so fucking small. So the fucking Handle with Care Act was campaign. Handle with Care, HWCC, is to stop
MSD. HWCC is to stop MSD. Healthcare with campaign is to stop musculoskeletal injuries. MSI. We'll just say MSI. Musculoskeletal injuries. MSI. HWCC. Stop MSI. So many goddamn things. Since changes have been put in place, there has been a marked since these changes have been put in place, there has been a marked decrease in reported lifting injuries in the healthcare workplace. The ANA has published safe patient handling and mobility, which includes the interdisciplinary standards for lifting and moving patients across the continuum of care. As at this time, a bill has been introduced to the U.S. House of Representatives to require safe patient handling programs in all healthcare facilities and to eliminate manual lifting in healthcare facilities. Have now instituted a no lifting program to relieve nursing staff to need to lift patients, instead using lifting equipment such as sit-to-stand lifts, hydraulics, and battery operated lifts. It is your responsibility as a nurse and student to learn how to use these equipment. Although it may at times seem faster to move, patients manually. That saved time is not the risk of injury and more than your body can tolerate. Nobody wants a lawsuit. Stop lifting. They don't want to get sued. Stop lifting. They don't want to be sued. Your own liability. Devices for moving and devices for lifting and moving patients. Various types of equipment are available to assist in the movement of patients, such as transfer belts, nylon friction reducing. The fuck am I reading? Various types of equipment are available to assist in movements of patients, such as transfer belts, nylon friction reducing devices, and slide boards, as well as partial or full weight-bearing assisted devices, including sling-type battery-operated overhead ceiling lifts, are becoming the equipment of choice at new hospital construction and remodeling projects. My life needs a remodeling project. Fuck. When patients are unable to move themselves. When patients are unable to move or turn themselves in bed. Okay, moving patients in bed. When patients are unable to move or turn themselves in bed, the nursing staff must do this. When the nursing staff or patients are able to move themselves in bed, nursing staff must do this for them. An overhead trapeze bar or triangular device suspended above the patient or over the bed frame allows the patient to lift some or all of his weight off the bed, which is helpful when moving a patient or turning a patient. Turning a patient. So we have moving the patients in the bed. We have transferring the patients. Annual transfers. Assist with ambulation, obese patients. Okay, so overhead trapeze bar, fucking goddamn trapeze boys. Suspended.
the partial trapeze are so trapeze bar helps in bed. Draw sheets are helpful. Draw sheets are helpful to move and turn. Turn the patient in bed. A draw sheet can be untucked and used for turning the patient. Before turning a patient on his or her side, it is recommended to move the patient toward the side of the opposite. So move the patient towards the side of the opposite bed of the direction in which you'll turn the patient. For example, if you want to turn a patient on his left side, you would want to move the patient towards the right side of the bed. Then when the patient is turned, he will be positioned in the center of the bed rather than the edge. Okay, so like so if you want to bring them this way, I want to bring someone left with a draw sheet, okay? I will move the patient right, so move him this way, so when I pull, he will be in the center. I'm gonna pull you this way, so I need you to go here. So he's in the center. Okay. You turn him. So you're turning the patient laterally. Hey, turn here. Shh. Pulled. Okay. Then, when the patient is turned, he'll be positioned in the center of the bed rather than the edge. So draw sheet. Draw sheet. Center. Difference between patient. When a patient has undergone, I need the actual nursing book. Goddamn, I really need the actual book though. That's the thing. I need the actual book. I can read some of it, but okay. A log rolling a patient. When a patient has undergone spinal, so we have turning a patient, log rolling a patient. When a patient has undergone spinal surgery or has a spinal injury, it is necessary to turn his or her body as one unit. Spinal surgery, spinal injury. Spinal surgery, spinal injury. His body is as one unit. This procedure is known as a log roll because the patient is turned the same way as a log would be rolled. The patient is turned the same way a log would be rolled. Three nursing personnel are required to correctly log roll a patient. One stands at the patient's head. One stands at the patient's waist. One stands at the patient's thigh. The staff members. So. Damn, so for spine equals paralysis. 3 count Don't F up. When the count is given, all 3 staff move the patient to the side that is opposite. Then 2 staff members.
Okay.
Transferring patient, we have the trapeze bar, we got turning a patient with a draw sheet, got the log roll for spinal surgeries. Nice. That's all in bed procedures. Now we have transferring procedures. You will often assist a patient out of bed to sit in a chair. Ah, my thumb, fingers. What time is it? It's 1? Damn. I'm spending my weekend studying. Researching, excuse me. I'm spending my weekend researching. Come on, we can do it. Transferring a patient. You will often assist patients out of bed to sit in a chair to move the bed. Transferring patients. I mean, what is this already? We're moving and lifting patients. What is this one? This was positioning patients. What was the last one? The immobility. So we built on it. You have immobility. Why do we have immobility? Well, to stop immobility, we need to position them for more better circulation and stuff like that. We have beds that can help with that, and then we have we have beds that help with the range of motion exercises and all that. We have positioning, right? And then we have moving and lifting someone. So this is from the bed to your fucking ass to fucking guy getting your rectal exam to fucking pregnant babies to fucking arm boards to pillows to blankets to fucking everything. This is one chapter. Fucking my life. Okay. Well, I just had a little existential. You often assist a patient out of the bed, sitting in a chair. It's all simple. A stretcher or wheelchair here from another area of the hospital is important for you to know how to correctly transfer or move patients from one place to another. Transfer equals from bed to blank. Blank's just before attempting approach, you need to know how much assistance the patient will require. If the patient can stand but is unsteady on his feet, you will provide ambulation. Only what the minimal assistance? Only minimal assistance? If the patient is unsteady, can stand but is unsteady on his feet, you will provide minimal assistance. However, if the patient cannot stand on both feet, perhaps one side is paralyzed, you will provide a great deal of assistance.
Ah, John Miller.
That sucks. Think of Miller. If a patient is unable to bear weight, you will transfer the patient using to accomplish this, you will need assistance of more than Lift equals unbearable weight equals 2 people. Wheelchair locked. Lock the wheelchair. Why don't they say this? Lock the wheel. These guys are bozos. Look at these bozos. Patient has left side weakness. Place a wheelchair on the right side. When you assist the patient from the wheelchair to bed, place the wheelchair so the transfer. The badge to be on his right side. My finger! My middle finger. Why? I have more to do. I'm feeling some nerve compression neuropathy. Low O2 in the skin. Ah! Come on. We can do it. Transfer belts. Once you know the amount of assistance a patient needs, you will determine what assistance device you will use to transfer. If the patient can fully or partially bear weight, you will use a transfer belt or a gait belt. This device is red fabric is placed around the patient's waist joint, which provides a slide sheets. Slide sheets are nylon friction reducing device made of thin sheets smaller than the surface. Okay. Slide boards are called transfer boards, or another method used to transfer bed to stretcher or stretcher to bed. Slide boards, hard plastic board, plastic sheet. Okay. Come on. Can we end this chapter, please? Bro, I molested this book, bro. I've actually never, like, writing
write in the margins of your book. Literally, don't spend your time making notes of what you're reading, or like reading then making Google Doc notes, or just making. Bro, all you have to do is literally read and reread, and then just make notes to yourself. Just interact with your book, bro. That's literally how. That's crazy. I'm literally sitting here talking to my fucking book. Like, can you believe it? Like, you piece of. I hate this shit. I hate this motherfucker. And I have fucking 4 other fuckers I'm gonna hate on too later today, so. Place on the bed of the patient, standing between the bed and the stretcher. The patient's turn on the slide board. Healthcare provider use the sheet to simultaneously slide the patient across from the board to bed to stretcher. So this is layered, right? Can a slide sheet be on top of a slide board? Yes. Sheet on board. Yes. Board on sheet. Why? No. Stop. Hyperstatic, idiot. Hyperstatic. Sit to stand lifts. Partial weight bearing assist devices known as sit to stand lifts are useful when transferring a patient who is in need of assistance, such as those who are weak, elderly, or recovering from surgery. So we have sit to stand, transfer belts, slide sheets, slide boards, sit to stand, who are useful from transferring assistance, such as those who are weak and elderly, recovering from surgery. Devices may include the bed and bedside common in the position page. Oh, okay. These devices may be used from bed to bedside to the bedside commode or bathroom. The patient is assisted to the standing position on a locked device. 314. Sit to shit. Sit to shit. AK. Sit to shit. Lifts, sling type. Traditional Hoyer. Lifts, sling type, battery operated patient lifts are used for the non-weight bearing patient, partial weight bearing parent. Non-weight bearing, these are rolled up and slide in a sling. In a sling construction of thin white material, several different types of slings are available. Proper training and critical care for trainers with these slings attached to the battery operated device, which raises the patient into a steady position. Level this lift is stabilized with the wide bits of board desired location. During this time, patient between the sitting and the sling, when he is gradually able to determine it, gradually lowered to the chair or wheelchair. Lock the fucking wheelchair. Oh my god. Literally, anytime I see wheelchair, when a patient has been transferred from when a patient has been transferred from the bed to chair, will require assistance from the transfer back to the bed. The sling is left beneath the patient. When the patient is later transferred back to the bed, the sling will be removed. Sling type, battery operated lifts. This device is preferred because nursing staff does not have to lower the patient's weight. Older model lifts are not battery operated but operating using hydraulics. While these will require some effort,
some effort to lever the weight part of the nursing staff. They're far more preferable than without assistance.
So we got the lifts. These lifts operate in the same way discussed as previously, except that the lifts operate in the same way as discussed previously, except that once a patient is centered in the sling attached to the lift, you must pump a lever. Yeah, so you got lever and battery. So it's all battery versus lever equals better than manual. Okay. Except that once the patient is centered, the sling is attached to the lift. You must pump the lever. The patient's sitting position. Once the patient is transferred to the desired location, a valve is turned on and released the gear, gently lowering the patient into the wheelchair. Overhead ceiling lifts are becoming more popular in the safe patient handling campaign. The safe patient handling campaign. When? That's not the campaign. It was the Handle with Care campaign. What is this? What is this other campaign are they talking about? Bro, a safe patient handling campaign? What the fuck? We got H handle with CC, now SPHC. So we have the Handle with Care campaign, now the Safe Patient Handling campaign. Dude, I got all these campaigns now. Real world connections, safety. Oh, I should play the Modern Warfare campaign. I'm gonna play the fucking Modern Warfare campaign. Fuck yeah. An elderly, or the Cold War campaign. Cold War campaign sucks. I'll play Black Ops campaign. I wanna play Black Ops. Is there like a Black Ops, Black Ops high res? Black Ops texture. I have something. What is like not submitted? July 20. Infection control. Okay, I'll redo these. Okay, I'll hand this in. I'll hand this in. Oh, I already handed it in. I'll hand it in again. Okay. Feedback available. Points 18. Okay. Yeah. Again. Okay, I really gotta keep my classes in order. I actually gotta keep this shit in such order. Okay. Real world safety connections. Safety tips for stretchers. An elderly patient was in a radiology department after a complete CT scan. He needs to be moved from the CT scan table to a stretcher. The stretcher was placed against the CT scan table and locked. A second nurse who was unaware that the stretcher has been locked presses the foot lock and inadvertently unlocked the bed. The patient fell between the CT table and the stretcher during the transfer when the stretcher moved unexplainably. Safety. Always verify stretcher wheel beds do not roll physically. Now they mention it? Oh They now want to mention like.
Who are these nurses? Who's Bozo 1? I gotta find Bozo 1. Okay. An elderly patient was in the radiology department getting the complications. He needed to be moved to the CT scan to the stretcher. The stretcher was placed against the CT scan. A second nurse? Where's nurse number 1? Where's nurse number 1? Bozo number 2. Where's the first nurse?
Okay, manual transfers. Although the use of assisting devices is recommended in the ANAs, now, okay, let's go. Let's get some abbreviations. American Nurses Association, a safe patient handling incentive. No, this is SPH. No, this is SPHC. Sorry, such devices may not be always available. Safety: if you must transfer a patient without an assistive device, you must use. Okay, if you must transfer a patient without an assistive device, called a manual transfer, you must use proper body mechanics. Proper body mechanics include using a wide base of support and standing close to the object being moved, keeping your back straight and avoiding twisting your torso, using your thigh muscles instead of the muscles in your back. Remember to explain to the patient what you will do and instruct him or her about doing the transfer. When you perform a manual transfer from a patient from bed to stretcher, a draw sheet, a bath blanket is helpful. First, assess the situation to determine the number of staff required to the safety transfer. Consider the patient's weight, level of consciousness, physical ability. For patients who can assist, use a transfer or draw sheet. Okay, so we got manual transfer. You got to use good body mechanics. You have good body mechanics. Explain. Body mechanics. Explain what you will do. Instruct him. Good body mechanics. Thigh muscles. Back straight. Avoid twisting. T. A. T. T. Teeth. Remember. Explain. When you perform any patient from a red stretcher or jaw sheet. We don't have these. A draw sheet. Is that a person? Is that a. Let's see. Is that a positioning device? No, it's not. What is a draw sheet used for? That's for patient repositioning, right? Slide boards, slide sheets. Where's draw sheet? Transferring. Turning a patient. Draw sheets for turning patients. Draw sheet. Turning patient. A bath blanket. First assistance to determine the number of staff required to transfer. Weight. So weight. We got level
of consciousness, and we have physical ability, PHA. For physical transfer, the draw sheet, roll the patient and place the draw sheet. Roll the patient and draw the sheet under the patient. Extend from the shoulders to use the thighs. If the patient's unable to assist the transfer, you can use a bath blanket under the patient from the head to feet. Then grasp the bath blanket and move the patient to stretcher. Patient lift devices. What's the primary purpose? Transferring patient unable to bear their own weight. What is the thing the first nurse should? What is the first thing a nurse should do when preparing to use a lift device? Make sure everything is locked. Wait, during the time the patient is sick. What is the first okay, let me ask this question. What is the first thing? What is the first thing a nurse should do when preparing to use? No, I don't need this. I need like an actual. Make sure everything's locked and amount of people are required. I don't know. There's no. What the fuck is the answer to this? Let me just close that. Safety numbers. Wow, I actually completed a chapter. Incredible. This is like the first chapter I've actually sat down and just like looked at and comprehensively just looked through. I like it. This chunking, that's good. Feels good. Feels good. Feels great. What the fuck are we doing? Uh-oh, that looks so sad. I actually gotta put study with me in the goddamn title. Are you fucking serious? I gotta put study with me in the title for engagement. Can you believe that?
4 hours just on one chapter? Abdi, you are a loser. I just spent 4 hours just reading about chapter 4. Oh my god, I gotta read so many chapters. I'm gonna get some good ass sleep tonight though. I'm literally gonna just knock out after this. I do got some shit to submit. A lot of shit to submit, and then I gotta read over. I'm gonna do a light read of chapters. Actually, I gotta do a deep read because I'm behind. Actually, I'll do that tomorrow. We'll see. Tomorrow will be a full fundamentals day. Fundamentals and then recap of some other things I did today. For sure, 100%. Because then I can look. I'm gonna read chapters 4 and 6. Nutrition 1, 2. I might have to do 3. I'll start with 3, go back to 1 and 2, and then read 6. That's not bad. That's actually not bad. It's actually not bad. We're gonna do a good review, and then we can actually hit the fundamentals later tonight with the review once I'm done this. So I'll take a little break. 100%. Okay. 100%. Supervision and delegation. Yeah, 100%. Let's get this money. When you're manually moving or transferring patient, it is, and I have some homework to do, so actually I'll do the homework before the fundamentals. I'll submit that, and then I'll probably try my best. Safety in numbers. When you are manually moving patients or transferring patients, it's imperative to carefully assess each situation. Be sure you have proper number of staff available to assist the move. Although you can delegate transferring patients to UAPs, a certified nursing assistant, and CNAs, it is important that you're aware of the patient's abilities. If the patient is unsteady, heavy, or weak, or paralyzed on one side, then at least 2 members of this nursing staff should at least with a transfer. It may be necessary to delegate additional nursing staff to assist with a patient movement or transfer patients to prevent patient and staff injury. Delegation. Assisting with ambulation. Manual transfers, assisting patients needing assistance with ambulation should move from supine position to standing position in stages to avoid possible dizziness or orthostatic hypotension. There's that word again. What does it mean? It's sinoscope. Sinoscope equals fainting. Hypotension, low blood pressure. Standing up, low blood pressure. I'm literally reading I literally have mind control. To safely move a patient from supine to standing position, raise the head of the bed and assist the patient on one side of the bed to ensure the patient is able to tolerate the position change. The patient should be firmly on the floor or footstool. This process is called dangling. If patient becomes dizzy while dangling, assist him or her back to the Fowler
or semi-Fowler position.
What the fuck is Fowler then, huh? Oh my god. Show me, bro. Show me Fowler's position. (45° and 60° is Fowler. So, what the fuck's 90 then? Is 90 considered Fowler? High Fowler 90. Okay. Bro. High Fowler 90. Fowler 45° to 60°. 45 to 60°. Low Fowler. What's semi? It should be 40. Fowler's is 46°. Semi 45°. Low 30°. Okay. Semi Fowler 45°. Fowler 60°. Semi Fowler on the bed. If the dizziness continues, lower the head of the bed to low Fowler position. If doing so is not contraindicated for this patient. Lowest. Once dizziness has passed, return the patient to Fowler position. Dizziness, so you want blood to get to the head. Check patient's blood pulse and blood pressure. Attempting to assist the patient to dangle again. Follow the patient to dangle for 1 to 3 minutes and check their pulse and blood pressure. If the patient does not experience dizziness and the pulse and blood pressure do not change significantly, allow the patient to proceed to the standing position with staff support available. However, if the pulse rate increases by more than 20 BP, the blood pressure. However, the blood pulse rate increases by more than, and the BP pressure drop more than 20, or the patient experiences dizziness, assist the patient back to the sitting position, lift the legs into the bed, and lower the head. So this is like all this shit is so patient's response to what? You're taking the person up. Okay, so patient's response to ambulation. So we have dangling, right? So you got to safely move the patient from supine to supine. We want to stop orthostatic hypotension, which means low blood pressure. Sinuscope. Safely move the patient from supine to standing. Raise the head of the bed. Then assist the patient to sit on the side to ensure the patient is able to tolerate the change. The patient should feet firmly on a floor or footstool is called dangling. All right. And then we gotta assess BP if the pulse rate
increases. So, pulse. Pulse rate 20.
Damn, my fucking head. I really gotta take a break after this. What kind of break? What do you like? 15 minutes, just do whatever. Be certain that patient is wearing non-skid footwear. Be certain is not wearing non-skid footwear. Place your feet in front of the patient. Place your feet in front of the patient's Place your feet in front of the patient's feet with your knees against the patient's knees to provide stability when he or she is moving from sitting to standing. A transfer belt may be helpful to provide the grasp hold of the patient experiencing dizziness. Assist him to the sitting position. When a patient is able to stand without dizziness, proceed with ambulation. Stand at the patient's side. Transfer belt. Your feet in front of the patient's feet. From sitting to standing. Practice it, but when the patient can stand without dizziness, proceed with ambulation. Stand at the patient's side for support. I just highlighted a whole paragraph. All right, lifting the patient with obese patients. Some patients are obese, which means they're 30% overweight. When you lift patients, move these patients, you must take care of protecting yourself and your patient from injury. Be sure to use equipment abused for the weight of the patient. And let's talk with co-workers. Move large patients to prevent injuries. It may be necessary to upsize the bed to the patients who weigh in excess of 300 pounds. Protecting yourself. Your knowledge of transfer techniques and body mechanics and the use of transfer devices are key to protecting yourself and your patients from injury. In addition, one mark of a good nurse is ability to anticipate possible problems and take steps to prevent these problems, such as the following scenario. A female patient puts her collar and asks the use of a bathroom for the first time after having abdominal surgery. A nurse A is busy and sends a UAP to assist, but gives the UAP no particular instructions. The patient becomes dizzy and nearly faints on the way to the bathroom. Nurse B thinks through all the patient's situation and realizes the patient's blood pressure is running a bit low and she has not been out of bed for 24 hours. Nurse B, although busy, goes with the UAP
They first assist a patient to dangle and then assist her to the bathroom, carefully monitoring her experience. So nurse A, I love him. Nurse A is not me. I'm not nurse A. Okay, what is that? 5 hours? Oh my god, my hair gets crazy. Ugh. I'm gonna not listen to this noise. Oh my god. There's no reason I shouldn't know anything about chapter 16. There's literally no reason. There is no fucking reason. Like, I've literally... There's no margin not full of chapter 16. Okay, we have chapter 17, which I can't wait to get to. Vital signs. Alright. Little break time, boys. Let me get this. Let me see how this work. These nuts. These nuts. Are they tied on? I spelled research wrong. I'm a fucking bozo. I'm literally a bozo. Should I put gorilla noises? Go away, fly. Go away. You're gonna get fucked up. You're literally gonna get fucked up. Copy. Gorilla noises. Fucking sick bastard. I'm down in my hands and knees, begging you please, baby, to show me your world. Gorilla noises. Okay. 6 vital. I kind of want to just read this, but I'm gonna get really bored, and it's about to paint. So how many pages did I paint today? 1, 2, 3, 4, 5, 6, 7, 8. Wow, that was 8 pages. That is so sad. That's actually Leo longevity 300 a day. Doing what? He does 300 a day doing fucking what? What a nerd. How do you read 300 pages a day?
took me fucking 8 hours to read. Oh my, for whatever, however many hours I can cover. Shit. I mean, oh my god. Fucking sitting here going crazy. Oh my god. Yo, I'm gonna go outside for like 2 seconds. Hey, relax. What is it? That's 14 minutes. Whew. Damn. sorry. I had to get my spiritual soul. I had to get some spiritual soul. I had to get some sun. I had to just look at the sun for like 8 hours, just looking at it. Fucking sun will kill us in 1.1 billion years, but it's okay. Alright, let's molest this chapter. What's left? 1, 2, 3, 4, 5, 6, 7, 10. Okay, let's get it. Define various terms associated with the assessment of the 6 vital signs. So there are terms. We have afibrile, ascapular gap, bivibration, bradycardia, bionia, chinia, stroke, respirations, diastole, diastolic pressure, dyspnea, apnea, febrile, hypertension, hypertension primary, hypertension secondary, hypotension. So high BP. Fever, hypothermia, loss of body, orthopnea. There's some more. Pulse deficit, pulse pressure, sinograph, sider, systolic pressure, trachea, trachea, and trachopnea. Okay. What kind of? How long of a break do I need to take in order for me to be like reassess myself in this shit? Right. Human body, the 6 vitals. We'll come back to these. Let me actually take a shit. I need to talk to someone actually too. I need to talk to them. Let me actually talk to someone real quick. Bro, this shit sucks dick. No, I'll do this fucking later. You're not home. Come on, you're home. Okay. No way, Enbound doesn't. He doesn't even. Yo. I'm a loser, guys. Nobody likes to talk to me. Yeah.
Let me put this right here. Bro, anybody? Fucking losers. Fucking loser. God, I'm a fat piece of shit. God damn. Well, I'm not reading till 5. That's for fucking damn sure. My ego wants to continue, but I gotta keep going. What time is it? 2 minutes. Okay. Define various terms associated with the assessment of the sex vital signs. The fucking medical terms, bro. Describe the 6 vital signs, their significance, and their ranges. 6, their significance, and their ranges. Identify times of vital should be assessed. Describe the internal and external factors affecting temperature. Identify
The Ryzen 7 3700.
Yo, NB.
That's what I have. And I
Bound.
have a Radeon RX 5700 XT.
What up?
Graphics card.
Bro, I'm sitting here. I've been studying for 5 hours, bro. Can you believe that?
But this CPU
So
is
tired.
bottlenecking, or GPU is bottlenecking my CPU.
Wait, what GPU you got? What are you talking about? I'll just leave. I don't belong here. All right. I don't belong. Yo, these guys they don't like me. Like fucking sitting here studying. He's not playing. Who are these people? These people, I don't know any of these. Okay. Okay, like you're. I just gotta keep reading. Nobody I know plays this game. Nobody I know plays games, bro. Okay. Like what? Ay caramba, this is garbage. I gotta just re-uninstall that. There's no point of that playing that shit. Identify the advantages and disadvantages of temperature assessment routes. So, how many routes are there? 1, 2, 3, 4, 5, 6, 7. 7 routes. 7 routes. Page 316. 17 point what? Identify nursing care for patients with fever. Describe the various peripheral pulse sites, factors affecting pulse rate. Distinguish the scale for measuring peripheral pulse volume. Distinguish the difference between inspiration and expiration. No. Breathe in and out. You are listening to a fucking beat. This shit's probably copyrighted, actually. Copyright background noise. Fuck this bullshit. Give me like. Is there rock music? Do I gotta. No. I guess. You know I don't like this. We gotta use this shit again. Oh my god. Identify factors affecting the respiration rate.
and abdominal respiration patterns. Right. The pattern. So rate is how fast, how irregular intervals. Outline 4 circulatory qualities. There are 4 circulatory qualities. And how they determine BP. Okay. So 4 circulatory qualities that make up BP. So we have hypertension and hypotension. Okay, identify factors affecting the pressure. So how they determine pressure and factors affect pressure. So first order effects. Contrast the effects of, man, I literally have like x-ray vision, okay? Hypertension, hypotension on the body. Okay. Describe to assess the document of pain, subjective, identify nursing interventions regarding vital signs and appropriate specific scenarios. Do not be dog shit. I cannot. Do not. I can't write that inside. Discuss information found in the connection features. Identify way safety information related to vitals. Okay. Critical thinking. Clinical assignment. While caring for your patient in clinical, you take his vital signs with an automatic vital sign machine or an automatic vital sign machine at 8 a.m. and get a temperature 98 degrees Fahrenheit, pulse of 64. Okay, what's a normal pulse range? Normal pulse rate. 60 to 100, so 64. BP 120 over 80 is like the 120 over 74 on the room. Manually it says respiration rate and 19 breaths. When asked about pain, your patient said his having abdominal pain on incision scale at a PALS. Your patient has a good morning and sitting up in a chair already. When you take his vitals, you see the same machine say 51, pulse rate less, BP down, oxygen down. When you repeat his vital sign information, you get similar readings, but a respiration rate at 17, with a pain assessment at 3. Why would you notify healthcare about his abnormal vital signs? His vital signs are his vital signs are decreasing, but pain is relative, but
respiration normal. So what's happening to this guy? His temperature dropped by 4 degrees. His temperature dropped by 4 degrees. His pulse dropped by 51, 50, so 7? Wait, no. 51, so 9 plus 3, 13. 14 actually. 13, 9, no, 13. 10 plus 1, okay. His pulse is 13. Oxygen's down. And his blood pressure is down and his oxygen down. Both of them are down actually. How would you... The BP looks weird. It does look weird. The oxygen looks weird. Why would you benefit from taking this vital sign mainly than relying on the machine? Because the machine could be wrong, okay. What should you be not sure, just had to teach a guy about cells. Common, man, it's just cytosol. Fucking bozo. Okay. Next course of action. Something up with the machine and dude. The human body responds to physiologically to all stimuli. Responds to the body physiologically to all stimuli, both internal and external. External stimuli include air, sunshine, environmental temperature, sound, any number of stimuli found outside the body itself. Internal stimuli includes hormones and enzymes. To provide appropriate care, the nurse must know how the patient's body is physiologically responding. One of the basic ways to determine this is to assess the patient's vitals. In this chapter, you will learn not only how to assess vital signs, but also how to relate them to vital physiological functions of the body. You will learn the implications of Implications means there's gonna be a lot of oh my god. Why? Okay. You will learn the implications of abnormal readings and appropriate nourishing care to provide. So, okay. The 6 vital signs. So how much is in this chapter? We have the 6 vital signs, which is overview. We got temperature number 1. So pulse number 2. Number 3. Number 4. What the fuck, man? temperature, pulse, respiration, blood pressure, oxygen. Number 5. Subjective 6. Six vitals, five objective, 6, 5 objective, 1 subjective. 5 objective, 1 subjective. The vitals are 5 objective, 6 subjective. Okay. The 5 objective and 6th subjective. The 5 objective and 6th and the 6th subjective. We're talking about vital signs, baby. Okay, vital signs overview. Let's get the overview in. Let's get this. Let's just get the general. We're gonna focus on the narrow. Let's get this chunking. You have chunk 1, chunk 2. Okay, baby, let's get this chunk 2. All right, we have chunk 2. This guy is fucked up. Okay. I'm gonna refer to this guy as boy dead as hell. Okay. Vital signs are the fundamental measurements of life sign. Fundamental measurement. So vital signs, the fundamental measurement of life signs include 5 up. Bro, how do I know this shit? I made this up. I made this. No, I did this. Bullshit. The 5 objective and 6 subjective? No. How? Bro. Dude, the subconscious is so weird. The instinct, bro. Follow my instincts. My instincts are so right. My instincts are wrong a lot, but like when I know it's right, it's so right. Okay. The 5 objective measurement and the 6 subjective measurement. The 5 objective measurement should be okay. We have. We don't even need to night. We got temperature. I don't want to put pulse for a second, but we have pulse, we have respirations, we have blood pressure, we have O2, 1, 2, 3, 4, 5, we have pain, 6. Alright, we got that chunk. Okay. The 5 tells you how certain systems are functioning and provide data regarding the patient's overall condition. So, body condition assessment. I'm calling this a BCA. BCA. Body condition assessment. Did you check his BCA? What do you mean BCA? His vital signs? Shut the fuck up, Abby. That's bullshit. All right, nobody's gonna determine this BCA, okay? The 5 objectives, how certain systems are functioning. Okay. Although subjective,
pain is important because this is the feeling of distress, and pain can have effects on the pulse, respiration, blood pressure, and serves as a warning that tissue are actually being injured or about to be injured. In fact, pain is one of the prominent reasons people seek medical care. No, exactly, pain. You're having pain. He's in the pain. He needs care. Medical individuals seek medical care because of pain. Now we need to identify where pain will be. Pain. That's why they say pain for last. They know I'm interested in that shit. You will assess and measure the vital signs often because it is a quick and efficient way to monitor a patient's physiological condition, identifying new problems and determining if intervention should be performed if or prior to interventions were effective. It is important to remember vital signs are only valid when they're accurate. The inaccurate measurement of vital signs can result in a range of serious problems, from failing to detect the deterioration to the patient's overall way to death. Okay, so death. It is important to understand that vital signs must be evaluated in conjunction with the patient's overall condition. Even though vital signs are one of the most important, it's like the daytime and there's no light. Thank you, Jesus. It is important to understand that vital signs are in conjunction with the patient's overall condition. Even though vital signs are the most important and frequent assessments that people make, they do not always reflect changes within the patient's condition. For example, a patient with serious respiratory illness such as pneumonia may still have the respiratory range. For further assessment such as breath sounds and chest effect are required to detect deviations in function and always look at the heartbeat. Are important when accurate. Vital signs are commonly delegated, but because of the skill measuring vital signs, people many times a day after day is possible.
You are responsible for analyzing vital signs to determine whether it actually has more than you took the look. There are times where you should stay still with the signs. So meds. Assess. Okay, this is assess and reassess. So meds. With certain change of conscious level, change in level of consciousness. What is that? I'm looking at or what is uncontrolled bleeding? Uncontrolled bleeding. It's called hemophilia. Hemophilia. No, not hemophilia. Hemorrhage. There we go. Hemorrhage. Not eng. Hemorrhage. Hemorrhage. The patient's Bro, I just was about to write hemorrhage. Bro, hemorrhage, shock, stroke, pulmonary embolism, heart attack, or any other serious condition. We're talking about embolisms. Anytime you suspect the validity of a photo. Boys be lying to your face like that. Occasionally there are times when you cannot identify. Subconscious. Occasionally there are times when you cannot identify a patient's problem or something just doesn't seem right. Never ignore those feelings. It has been proven that we subconsciously detect subtle changes in the patient's condition without being able to consciously identify the change.
It's always better to repeat a vital sign assessment and find nothing out of the ordinary than to miss upon but do not reassess. Rather be safe. Rather be safe. Rather reassess. Rather reassess. Right? There are delegations.
Designated. Oh, my brain. My brain. I barely ate this page up. Oh my god. Mother of God. Mother of God. We totally fucked up. Bro, I totally fucked up. Oh my god. Okay. It's okay. Okay, it's okay. It's okay. It's okay. It's okay because what? We have. It's okay. It's okay. It's okay. So what do we got? 1, 2, 3, 4, 5, 6, 7, 8, 9. Of just okay. There are designated times for assisted vital signs. Most hospitals have them routine every 8 hours. So PS equals 8 hours. Unless healthcare measures are more frequent. Okay. 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 It's okay. It dawned on me. Vital signs every 8 hours. Vision needs to measurement in shorter intervals.
It's a series of major vital signs that are taken at the emergency to the facility. And represent part of the initial shift head to toe assessment. About 1701 was able to assist. Further guidelines for assessment of vital signs were using appropriate equipment for each patient, such as child patients be familiar with normal range of different ranges. Always compare vital signs with previous vital signs. Ranges per age. Vital signs. Know the patient's medical history, medications, therapy, and they have predictable vital signs. The obvious. So I'm gonna call this the obvious factor. Medications. Therapies, because I have the obvious factor, medical history. Okay, understanding the interpret the vital signs findings. What they mean. Rob. Medical terms. Record and communicate significant vital signs of changes. So healthcare provider switch shift. VS changes. Minimize environmental effects and vital signs such as
what can I write this as? Environmental object.
Object causing interference of VS.
Okay, alright. At least five times or situations when you should assess vital signs rather than delegate them. List 5 guidelines regarding the assessment. What do you mean 5? There's 5 situations like change of consciousness, post-operative, uncontrolled bleeding, and then at least 5 guidelines regarding each. Have appropriate equipment, know the normal ranges. So your responsibilities. So okay. So assess. Assess. We have we have
level of consciousness, we have suspected hemorrhage. Fake reported. Medication. Meds. Anytime your gut tells you. Guidelines. Right equipment. Ranges of BS per age. We got compared to previous. We got we have 1, 2, 3, 4 changes. Record changes of vital signs. Understand what
Okay. And when to assess. Wait, that was when to delegate? When not to delegate? These are times. When not to Della VS. When to assess vital signs. Every facility will have designated times, such as specific time on each shift. However, there are many situations and circumstances in which you report assess the vital signs of the patient. It is your responsibility to identify what may be necessary to perform this common by such as addition time to assess vital signs. We're on to admission of hospital. Clinic or emergency two. Shut the fuck up, bro. At each home or hospital visit. 3. Every 8 hours according to hospital policy. Easy 4. 4. According to healthcare provider orders.
They are more frequent in hospitals. 5. Anytime a patient complains of unusual difference or different. 6. When you suspect change in condition. 7. Before, during, and after administering treatments that may affect the physiological controls. So 8. Meds that VS times 3. Before, during, and after blood product transfusion. 9 times 3. Before, during, after surgical procedure or major diagnostic procedure. 10 times 3 VS times 3 VS times 3 VS. At least every 4 hours whenever one or more vital signs are abnormal. 4 per hour when last when 1 plus VS 4 per hour when 1 VS abnormal on a second time or more. Times 2 plus when pre VS eleven 12 times 2 when post VS is diff to pre-VS. Every 15 type unstable delivery surgery or trauma. 5 through 15 unstable trauma. Birth. No, vital signs are routinely assessed only once a week or once a month. Long term. LTCF. Sad. Oh, my hands are fucked.
This is some research, boys. I really said I was gonna do it. I really said I couldn't do it. I can do it.
Body temperature is the difference between the amount of heat the body produces and amount of heat that is gained or lost to the external environment. The core temperature is the temperature in the deep structure of the tissue. Oh my god, how many of these were? Hold on. 10, 11, 12,
So 13. So 13 times 2 times 6 Okay. On admission to the hospital, emergency room, hospice visit, 8 hours according to hospital policy. Healthcare providers. You have healthcare provider orders. Plans about unusual feelings. Suspect a change in condition. Before, so medications times 3. So medications times 3. So medications, that's times 3. Blood so meds, so we have 13 meds times 3 VS. We have blood trans times 3 VS. Surgery times 3 VS. Ab VS times 4 per hour. Times 1 per 4 hour. Second after ab. Five to 10 unstable. So we have 7. We have 7 reg. 7 reg and 1, 2, 3, 4. Wait, we have 1 before or after medication. 2, 3, 4, 5, 6. 5 reg, 6 multi. You have 5 reg and 6 multi. Okay. Alright. God damn. My fucking head hurts. Body temperature is the difference between the amount of heat produces in the deep structures and tissue. The core temperature is the deep structure and tissues. It is normally slightly warmer than the superficial body mass tissue. The core temperature is important and maintains a condition in which the brain, heart, and other internal organs must survive. So core equals internal organ temps. Measurement of the true core temperature is accomplished with a sterile thermometer probe into the pulmonary bladder. However, in most circumstances, it is adequate to measure the body temperature. It's adequate to measure the body temperature. Temperature assessed by laying your hand on the patient to determine if their skin is warm, hot, or cold, as well as if they're dry or moist. Or general heat or cold. Oh my god. Research. 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 Reading and searching for the answers. Okay. Healthcare scales of measurement. Healthcare provider measure body temperature using Fahrenheit or centigrade, also known as Celsius. Thermogenesis. The production of heat is known as thermogenesis. One of the ways body produces heat is through the process of ingesting food, digestion, absorption, breakdown, and synthesis of proteins. Because of intake of food results in increase of metabolic functions. The body's heat is a byproduct of metabolism. More heat is produced as metabolism speeds up. So, heat. When less is produced, when metabolism slows down, less is produced in the body. So the nasal basal is a heat burn when the body is at total rest. Basal. Total rest, because any increase in metabolism Okay. Shivering is involuntary. Exercise. Doonies. so tired. Oh my god. Alright. This is why we can't do all the reading in one day. We have to space the reading out, Abby. We have to space the reading out. When it comes to Friday, okay, so I gotta do okay. I gotta read early. I really have to read every day and early, okay? That's I literally have to read every day and early. Okay. Good. Okay, numerous other okay, so we have body temperature regulation, well, hypothalamus. Ooh, hypothalamus. We have 114 as boy dead as hell. We're dead. From 41 degrees C to 44 C plus regulation. .97, so basically 97 to 98.6. 41 degrees. What are they saying? Fucking 41 degrees C to so like the fuck is this 41 degrees C? I hate Celsius so much. Efficient. C2. So it goes upper limit, so it goes upper limit heat stroke fever slash fever fever normal lower limit my fucking finger. What did I do to deserve this life? Oh my god. It just goes to, okay, so it's from 0 degrees Celsius to 0 degrees Celsius and negative 29. So we have, for the hypothalamus, temp reg lost, temp reg impaired, best temp best optimum range, optimum temp reg range, temp reg okay. Other factors. So this is just temperature. Okay. Vital signs overview. We learned at number one of the. We're still learning it actually. Numerous other factors influence heat production, including the hormone thyroxine. Thyroxine. Why am I thinking of blood, which is produced by the thyroid gland? It's produced by the thyroid gland. Epinephrine and norepinephrine secreted by the adrenal medulla. And adenine triphosphate, ATP, adenine triphosphate, epinephrine, norepinephrine, epinephrine, thyroid, which is an energy source produced in cells during cellular respiration. Liver. Other factors are the glands. So we have 3 glands. We have thyroid, adrenal, and thyroid gland, adrenal gland, ATP for cellular respiration. So glands, respiration, and then where's my highlighter? Liver equals 15%. Body. Okay. Older adults may also maintain a normal body temperature. This helps contain fat into a circulatory impair will impair visual distraction. So circulatory equals temp thermogenesis, temperature thermogenesis. So depending on their heat, we're looking at the heat. Thermoregulation, or the regulation of body temperature. And the thing, bro, I gotta shut the fuck up. Is primarily controlled by the part of the brain called the hypothalamus. Where is the hypothalamus? Damn, he's in there. What is that? What is that? What is this? What is this? Okay. We learned where the hypothalamus is. How have I never knew that? Pretty much behind eye level.
under prefrontal just below
That's crazy. That's where the hypothalamus is. Motherfucker, I be feeling the temperature. Alright.
When the hypothalamus is functioning correctly, it maintains a comfortable core temperature known as the set point. Hypothalamus says the thermometer. When the set point is exceeded, signals are sent out, causing the body to sweat and blood vessels to dilate, vasodilate. STP is exceeded. Sweat, more blood to the skin surface for increase in heat loss through radiation.
Okay, so set point is exceeded, signals are sent, body sweats, 1, blood vessels dilate, vasodilate, 2, that makes more blood to the skin for increased heat loss. So he's hot. Set point, I'm hot.
Okay. The sweat helps the temperature through evaporation. When sweat produces high enough to be seen on the skin, this is called diaphoresis. Not diaphragm, diaphoresis. The hypothalamus has capabilities to increase heat production by causing the muscles to shiver and to conserve body heat by constricting by vasoconstrict the body. This vasoconstriction helps the majority of blood flow to the vital organs, primarily the heart and brain, and maintain adequate core temperature. Many internal, we were talking about the thermoregulation, internal and external factors are affecting body temperature. Some common are the environment. So, 10 factors. Environment. Time of day. The climate and temperature of the environment affect the body accordingly. If the environment's hot, the body will tend to when the environment is cold, the temperature will tend to be lower. Okay, time of day. The body has a time clock of rhythm known as circadian rhythm. This physiology makes between 24 hours. So internal 24-hour clock temp drop 0.521 F 12 a.m. Raise 1 to 2 F 12 p.m. Mid and noon. Outside hot equals person hot cold person cold patient cold. Time of day, gender, only slight differences are found, however women to have has been proved to anyways, any ways oh my fucking, let me just stretch. Physical activity and exercise. During activity and exercise, muscle require fuel in the form of glucose to be metabolized or burned for energy. As mentioned earlier in this chapter, metabolism increases body. Okay, so exercise increases temp increases because energy temp. Medications, stimulants, meds, food intake, food equals metabolism. Note, hot and cold foods interference measurements Stress. People are anxious and stressed due to stimulation of the sympathetic. Heat. Okay. An illness is various. But a heat stroke is. How did an illness? How can a heat stroke's not an illness though? That's a problem. I really need to get to this page, so let's get this review done. Let's just get this details. Oh my god, I can feel the fucking pen finger just pulsing. Funny, because we're going to pulses. Haha. We're still on thermal. Oh my god. We got this. We got this. Gender, physical activity and exercise, medication, food intake, stress, illness. So hypothalamus. So head injuries. Heat stroke, viruses. Explain what's meant by the set point. Hypothalamus sets a point. Hypothalamus sets Okay, set point. Hypothalamus sets a point. Sets a Hypothalamus sets a point comfortable where air won't interact. Sets a point. Where it won't interact with thermoregulation because it's comfortable. 5 factors that can affect body temperature. Well, there's the environment. So you have environment, physical activity, stress, gender, time of day. Time of day. The meds. Describe how the body regulates its temperature. Set point above. Set point below. You got vasodilation, sweat, vasodilate, set below, shiver, constrict. Types of thermometers. Okay. Those thermometers that so what there's 4. I'm looking. 4 types. Plastic non-mercury. 1. Disposable chemical strip. 2. External. 3. Sympathetic. 4. Support artery. 5. Plastic non-reactive digital readout with oral sensory and rectal settings required to preset them. Some disposable chemical strip thermometer for topical application to the skin and others. Electromagnetic use to assess oral auxiliary and rectal temperatures. Tympanic is used for the measurement of the tympanic membrane of the ear. So we have non-plastic. Digital readout, oral and plastic non-mercury. So PN thermometers, oral disposable chemical strip thermometers. 2. Topical spin application. Others are designed for electrothermometers may be used as orally. Okay. Routes for temperature assessment, body temperatures. And body temperatures was actually rich in blood supply. Rich blood supply, the common is the oral, axillary, tympanic, skin, tympanic, temporal, and rectal. So we have your mouth, you have your armpit, your ear membrane, your skin, your side of your temple, and your ass.
Okay. Okay.
It's most accurate when
What did I? Gotta see some chapters.
oral is considered the best non-invasive method to obtain. Oral, best non-invasive. The thermometer is deep in the sublingual.
Bro, fly, get a life.
Auxiliary consists of placing the thermometer under the door in the armpit. Since the pattern has a special flask from the ear canal and temperature of the pattern membrane, the scanner of the thermometer can be used in the membrane with continuous observation of the body temperature. A probe of chemical stability applied to intensive heat is sometimes applied to continuous and one reported by a steel catheter probe to the pulmonary at each.
Oh my god. Jesus fucking Christ. 1, 2. Alright, let's just take a little break. We gotta take a little break. There's gotta be a little break, okay? Alright, there's gotta be a little break. Okay, we will just read chapters 1. Start with 3, read 1 and 2. This shit is 1 and 4. Probably 4 and 6. All we really gotta do is read like the
distinguish protein energy nutrients, contrast nutrients and non. Defining these two examples of essential amino acids in a great nitrogen balance condition in which energy metabolites predominate. Explain the difference between complete and incomplete protein. Give an example of food. And I like those describe how proteins Define vitamins. Differentiate between fat soluble and water soluble. Describe the ideal vitamins. Describe the dishes caused differentiate diseases caused by differentiate vitamins A and B. It's for diseases caused by specific water soluble to water. Look at two vitamins with food sources on affect your food. Differentiate between eventual and fortification. Distinguish between two vitamins associated with toxins from natural food. Name 3 food sources of probiotics A and C. Name 3 food sources of probiotics. Describe the prudent use of vitamin supplements with a two larger population groups from which segments and fortified a recommendation. This would from larger. Okay. That's actually not that bad. Okay, we'll do that. Read chapter 3 of this. And then 6 actually. It's like working from 9 to 9 or 9 to 7. That's 8 hours, right? How many hours? 7. I come to working at 9 and leave at 7. So 9, 10, 11, 12, 1. 9, 10, 11, 12. And then that to 7. 7 hours. It was 10 hours. It was 10 hours. Okay, so damn, I'm actually just doing basically a shift that I would do at work. Damn. It's actually pretty stupid. But at work I wouldn't be using my head like this. I'm just my head's on literally. Okay, well, where are we at? For continuous non-invasive body strip, sterile catheter probe in the pulmonary artery, each one has advantages and disadvantages. To accurately measure or most after applying disposable thermometer, the thermometer should be placed deep in the ciliary pocket. Make sure the patient is able to hold the thermometer placed with the thermometer. If not, slip the thermometer out for temperatures. Possible 50. Okay, so 15 to 30 after food, place under 12. Easy to use. Auxiliary route is patient who cannot. Auxiliary route is used for the patient who cannot hold the tone in one place or patient who's in the oral route. Post safety risk that your patient was having seizures, place the plastic. Okay. Space.
I need a sun reboost here in a minute. Ugh. Or a piss break, actually.
Gently pull the pin up, back on adult and down.
It's my head's actually really fucking hot right now. Skin, if disposable,
If using a disposable in that year, point down times 2 or 3, record highs.
skin, use a disposable chemical strip. If using a disposable chemical,
Peel the back off and back apply the stick of thermometer. If using special thermometer with skin probe, take the probe to the skin and observe the continual temperature of the skin. If skin is
you may use a non-mercury thermometer, which is defined specifically just for one page. Chapter 15's already been on. Bitch! Cause the body. Okay, temporal artery. Now we have 7 advanced. Okay.
skin. Oral. Advantages. 1, it's more accurate. 2, it's convenient and accessible. 1, risk of bodily fluid exposure. 2, risk. 3. Nope. Inaccurate probes are pointed. Routes, we have oral, auxiliary, tempatic, temporal, skin, rectal, and catheter. Nigga, where's the temporal fucking site, bro? Oh my god. What fucking ever. Oh my god. Now we're getting to the medical terms. We just got done temperature. We're not even done temperature. Oh, yay. What is this bitch? The vital signs? Come on. Oh my god, so we just got done 1, 2, 3, 4, 5. We're not even done 5. Actually, we're gonna get to 5. We're about to get to, we're pretty much done 5. We're done 5. Oh my god, there's another. Oh my god, another 13 more. Okay. We have there are 13 more. Too easy. 13 more. Okay, too easy. Too easy. Elevated temperature. Various terms to indicate body temperature, including fever, pyroxia, hypothermia. The term. What's pyrexia? Huh? Can you tell me that?
Anorexia. Temperature. A temperature. Oh, fever.
The term febrile is used in the state of having a fever. Afebrile is to be without a fever. Hyperthermia is body temperature above
104. Let's go back to our thermometer.
We have hypothermia, heat stroke or high fever. Hyperthermia.
We have 100 to 104 is normal. It's normal strenuous activity. Okay.
Fever is a body's natural way of protecting itself from. Fever equals fighting bacteria, viruses, and other microorganisms in foreign bodies and invading the state of health. After invaders enter the body, in which they do, the body stimulates special kind of white blood cells.
White blood cell cytokines. Cytokine.
Cyto. Phagocytes secrete the body stimulates special kind of white cells purpose to ingest the invader. These special blood cells are known as phagocytes. So WBC fags. White fags secrete progens which stimulate secretion prostaglandin hormone. Progens alert so they alert. So phagocytes release. So okay. So fags pyrogen prostaglandin prostaglandin trigger the hypothalamus to raise set point. This equals fever.
Nice. I don't know what a fever is. Nice.
An effort to so raising the set point
To inhibit microorganism.
set point. Increase microorganism repo decrease. To assist the temperature, the body tries to conserve body heat through vasoconstriction.
Interferon. I've never heard of this thing. Interferons. A protein released by animal cells usually responsible for child's property. How? Oh my god, are you fucking serious? So where does this start? Virus, respiratory virus hits the epithelial cells. Deficient interferon, type 3 interferons, INF, that thing, binding to ISGF to ISGR, secretion of ISGs, virus clearance, binding to S. Type 2 interferons, NFY, NFA, ICL, TH3 cell. So there's multiple processes happening here.
Because a fever is the body's natural fight against infection, you have to practice a lot of fever to combat it once it becomes bad. Oral 98.6 patty, 98.6 rectal, 99.6. Why does this feel so good? Nasty.
There's gonna be a couple hour break, but I got a lot of. Oh my god, I still have chapter 2 to do. In chapter 21. Okay, we have one. How many pages is this? 1, 2, 3, 4. We're on to the 4th. There's 13 of these, so we're making. It's only 2:20. It's only 4:20. I can take a little bit of a break, but I will have to come back to this. There's no shot I do not come back to this. Respiration, blood pressure. All right. Let's just finish up temperature. We're almost done temperature. Signs and okay. Bro, fuck off, fly. Temp. It's like the worst time flies want to fucking come. Go suck a dick. Okay, symptoms of signs and symptoms. I don't know why I have never drawn pictures. Every patient with fever will not present in the same manner. Some common signs and symptoms may indicate fever include flushed face, dry hot skin, dry mucous membranes, elevated pulse rate, glassy, droopy eyes, increased irritability, restlessness, photo fever, which means I have increased light, thirst, headache, mild muscle aches, lethargy, drowsiness, diaphoresis, sweat. Anorexia, nausea, confusion, especially to children, relevant seizures, especially infants and children. Caring with patients with a fever. In patients with a fever, you want to perform the following. Assess all vital signs at least every 2 hours. Fever, vital signs, 2 hours. Provide fluids frequently and measure intake and output as soon as fever is detected. It is important to remember that all your patient will have additional need for adequate fluid up to 3 liters per day to allow for proper cell function and prevent dehydration. If you detect signs that a patient is dehydrating or is not taking adequate oral fluids, it is your responsibility to notify healthcare providers responsible IV fluid orders. Okay, so frequent fluid intake and output 3 liters per day. Signs. HPC or possible Take extra care of foods. Take extra care to offer foods the patient likes and offer Oh my fucking god. Is it actually gray already? Why is it so gray? Okay.
Apply cauterized base. Describe how and why the body raises during illness. Inflammatory slash system response. At least 4 signs and symptoms of fever. Flushed face, dry hot skin, external elevated heart, eyes, 6, 7, 8, 9, 12. At least 3 nursing actions you take to prevent vitals. VS 2 per hour. Fluids. Change cloths if diaphoresis. Mouth, skin care, antipyretic. It's important to educate your patients on the proper medications in fever in children. Acetaminophen or ibuprofen may be used in fever in children. Avoid solidicities, including aspirin in children less than 15 years old age, for an increase of Reyes syndrome. Reyes syndrome is an acute potential fatal childhood disease affecting the central nervous system, and labor and death has been associated with it. So, children fever equals aspirin, liver, and CNS system pathology. Fuck you, pen. I'm not pen. Fuck you. Ah! I hate fucking flies. Go the fuck away. Oh, let me turn on the. Turn on the fucking AC. Where did the sun go? Where did the sun go? Where did all of that beautiful sun go? Damn! I missed the sun. Ah. Let's finish up. Okay, we'll go outside after hypothermia. Hypothermia is a core temperature below 95. Slow body metabolism. Though hypothermia may be induced deliberately to reduce a body's need for oxygen during neurological or cardiac surgeries, prolonged or severe hypothermia can result in death. Mild hypothermia is shown with warm clothes, blankets, and ingestion of skin. Because up to 40% of body heat can be lost. Is generally treated additionally with patients with severe hypothermia should be brought up to normal temperature because risk of irregular heart attack. Yay, we're done temperature. Temperature is done. We just killed temperature. We'll have to go back to it though. There's a lot of things we gotta know. Pulse. Fuck my ass. Okay, we have the pulse assessment. Blood pressure. Systolic, diastolic. Okay. Let me go see the sun before it sets. It's fucking 5. Why would the sun set? What kind of large ass cloud is above us? Making me feel all depressed and shit. Damn.
It's so fucking cloudy. It's so fucking cloudy. It sucks. Literal fucking dick. It's Dickie McGeezax outside. No inspiration. Where is the light? The light's at the end of the tunnel. They promised me. They promised me and they lied. But guess what? We just got we just got temperature. Time for pulse. The heart has so let's see, what did we just kill? What did we just kill? We just killed identifying nursing care for patients with a fever. Boom. So this was all temp. This is all pulse. This is VS. Temp. Pulse. Resp. BP. Pain. Extra. Okay, so we've got temperature down. Now it's time for pulse. The heart's 4 chambers. Heart, 4 chambers. Contract. With each contraction of the ventricles, oxygenated blood is forced out of the left ventricle through the aorta to be delivered by the body's arteries. The amount of blood discharged from the left ventricle with each contraction is known as stroke volume. The amount of blood discharged from the left ventricle, so from the LV equals stroke left ventricle blood wall. This pumping action, so the heart's a pump with 4 chambers. Think of like an engine with 4 pistons, 4 chambers. 6-cylinder, 3-cylinder. This pumping action results in a fluid wave of blood that travels through the arteries as they rhythmically expand and contract. This arterial fluid wave can be palpated as a gentle pulsing, a tapping, or throbbing sensation at various points of the body. This is called a pulse.
arterial fluid wave. The pulse corresponds with the contractions or beats of the heart and is counted by beats per minute. The volume of heart pumped from the volume of blood pumped from the heart in 1 minute is called the cardiac output. Volume of blood per min equals cardiac output.
So we have the left ventricle volume, which is the stroke volume. We have the volume of blood pumped from the heart in a minute, which is a cardiac volume. The heart pumps approximately 5 liters per minute. Average adult cardiac output equals 5 L's per minute. The central or primary pulse site is located over the apex of the heart where the contraction is strongest. The apex of the heart is a cone shape at the end of the left ventricle. So we have one. Okay. We have one. Just a minute. I can't feel shit. Okay, so we have here. Okay, so we have the sternum. One. Two. I'm thinking like right here. I have to be right here. Right here. I'm like. So it's like right, it has to be like right here. It's like right here. This is my ribs. So from the end of the Okay, all right. I'm looking for it. Actually touches the It touches the anterior chest wall or near the fifth intercostal space. The spot is known as the point of maximum impulse. PMI equals in a child, it may be found in the fourth intercostal. You should be able to feel the PMI with your fingertips. The PMI side which so
Apical pulse. When oscillating hearts, okay, when oscillating the heart sounds, you normally hear two sounds called S1, S2, or lub dub. S1, S2. Together, these sounds represent one complete heartbeat. If both S1 and S2 or lub dub sounds are heard clearly and distinctly, the volume or shape of it is described as distinct or strong. So distinct and strong apical pulse. If it's not heard, it's described as distinct or strong. If the heart sound cannot be heard distinctly, it is described as muffled. The apical pulse should be the same rate as the peripheral pulse, but if the heart does not pump effectively, blood flow may not be strong enough to continuously deliver fluid to more distant sites of us. Often this occurs when the pulse is irregular, resulting in an apical pulse rate that is faster than the radial pulse rate. When the radial pulse rate is slower than the apical pulse rate, when it is slower than the apical pulse rate, it's known as a pulse deficit. For example, the heart rate may be 83 beats per minute, but the radial pulse is only 77. This would be described as 6 beats per minute and should be recorded and reported. The number of pulse deficit in the previous example represents the number of heartbeats in which the forces of heart contraction fails to produce a pulse wave strong enough to be felt or profuse. Beats do not profuse are ineffective at circulating blood. Presents okay. What makes a heartbeat? What makes a heartbeat? Contraction of the heart is the function of the cardiovascular system, but the rate of contraction is regulated by the medulla oblongata, which is located in the brainstem. So medulla cardiovascular temperature, which is located in the brainstem in the central nervous system. In a normal healthy central nervous system. In a normal healthy heart, concentration of the heart and heartbeat initiates at the synovial node. In a normal heart, contraction of the heart or heartbeat initiates at the synovial node at the top right of the atrium in the form of an electric impulse. This impulse is conducted through the atrium on the electroconductive pathway, causing the atria to depolarize and contract. Thus, the impulse continues on the electroconductive pathway through the atrial ventricular node. So it goes from the synovial node. So it goes from synovial node at the top atrium electric impulse depolar this impulse it continues on the electrical pathway to a V top right ventricle. From there, the impulse is transmitted through a bundle of his and Purging fibers through both ventricles. Once the impulse has been transmitted through both ventricles, the ventral depolarized contract. As the ventral's contraction begins, the AV valve, known as the tricuspid and bicuspid valve, slams shut, causing the first heart sound. The longer and lower pitched sounds, known as the S1 lub. As soon as the ventricle begins relaxing, the semilunar valves, known as the pulmonary aortic valve, closes, causing the shorter, sharper sound of the S2 dub. Thus, a pattern of normal how it sounds in the rhythmic lub dub, lub dub, lub dub.
So lub.
So let's get this right.
Let's get this right. S1. Lub dub electric. Lub dub. Man, you better just let me see this goddamn freaking picture. Tricuspid valve. Closed shut. So lub is just
So lub is just the tricuspid and bicuspid. Close. Dub equals pulmonary and aortic valve closes.
lub is the tricuspid and the bicuspid valves closing. There's an electrical path that goes through, and then dub is the pulmonary and aortic valve slamming shut. Okay.
There are various pulse sites where the body may be palpitating. A gentle finger tap pressure over the artery against the underlying bone. These are known as peripheral pulses. We got 1, 2, 3, 4, 5, 6. We got temporal timpans. Used in cardiac arrest and cardiopulmonary resuscitation. Brachial used to measure BP. Radial routinely used for pulse surgeries. Ephemeral used to determine circulation to light pop.
We know where these are. Ulnar is this, radial is this. Any peripheral pulse can be used to assess the heart rate. Okay, so we just got the pulse sites. Yeah, pretty much what the pulses, the pulse sites assessment. You as a nurse. Three characteristics. Pulse assessment is three characteristics. You have the rate, rhythm, volume. So the rate is time, rhythm is pattern, volume, the amount. The normal pulse range for adults is 60 to 100 BPM. A pulse known as below 60 is bradycardia. Numerous factors affect the pulse rate. Rhythm is determined comparing intervals between beats. If the beats are evenly spaced, the rhythm is short as rhythm. If there are difference in intervals, if peripheral pulse rates are calculated with each so rate is beat per minute. Rhythm volume of strength of radial pulses is somewhat subjective in its significance when he assess. If populated rate is easily detected, described as a strong 2+, this would be considered normal finding. A pulse that's faint or difficult to categorize or weak is +1. If a pulse is so weak that the slight fingertip pressure on the pulse results in the pulse disappearing, it's classified as thready or feeble. So vol is +2 strong. Shit. Fuck. My ass. Someone just fuck my ass. Fuck my ass. Fuck my ass, please. So strong. 1 plus weak. So weak. It disappears. Thready slash feeble. Thready pulse disappears or obliterates. Inadequate volume is being injected into contraction. If you cannot populate the door. Man, now it's time to turn on the light. Are you serious? I've been sitting here that fucking long. I gotta turn on the light now. Damn. 1, 2, 3, 4, 5, 6. Age, newborns, 1 to 2-year-olds. Adults always have 60 to 100. These people have 80 to 100. 90. Pulse rates are slower from pre-dawn hours to dawn hours and faster as the day progresses. hypoxia. Okay. Hypoxia. Man, ain't nobody trying to see this shit. We got pulse. Pretty much done pulse right here, huh? This is like the nurse's assessment. Pulse assessment, yeah.
So we have skin color, skin temperature, sensation, capillary refill time. Blood
Okay. And yay. Pulse done. Pulse down. That's 8 peripheral sites. Temporal. Ulnar. Radial. Popliteal. Femoral. Distal pedalis. Some other one on the foot, I guess. 1, 2, 3, 4, 5. It just gives me 6, 7, 8. Okay. Posterior tibialis, dorsal pedalis. Posterior tibialis. Femoral, choroidal, brachial, radial, femoral, popliteal, posterior tibialis, dorsal pedalis. Okay. PD. Think of P and D. We have temporal, choroidal, brachial, radial, femoral, P and D. Posterior tibialis, dorsal pedalis. Nice. Very nice. 13 factors. 3 rhythm, rate, strength. Very nice. Respirations, number 3. Respiration. Okay, assessing for the extremity and proximal distal process are signs of adequate circulation. Obtain a Doppler ultrasound machine, a device that uses sound waves to determine if blood flow is present. Listen for the most distal peripheral pulse that you are unable to palpate to confirm that there is adequate arterial blood flow to the site. All right, let's hear it. Let's hear it, Dr. Abdi. You seem to know what the fuck you're doing. You just think you know what the fuck you're doing. So if this is my sternum, this is the end of the sternum, so up and like right here. End of the sternum, up and to the left. I can hear it in my ear, but I'm not sure if that's me or if that's my... No shot. There we go. I hear it now. That is very fucking cool. I literally hear my heart. Okay. Damn. Thank you, buddy. Thank you, Pulse. I've been talking shit about Pulse. Oh my god, that does make you lightheaded. No shot. Okay. That is fucking hilarious. Alright, respirations. Let's get to the lungs. Oh my god, the words. The words. Let's finish this off, baby. Ah. Respiration is the interchange between CO2 and CO2 between the atmosphere and the body. It involves both external respiration and internal respiration. External respiration is exchange between the gases between the lung alveoli and the blood and from the capillary that is found surrounding the alveoli. Internal respiration is the process of exchanging gases between circulatory blood and the tissue cells that make up the body. Okay. Exchanging gases between circulating blood. Exchanging gases between circulating blood and the tissue cells in the body. The movement of air into and out of the lung is called ventilation. The mechanics of respiration involve the act of breathing in, termed inhalation or inspiration, or breathing out as expiration, or exhaling or expiration. Although the act of breathing is a function of the respiratory system, it's regulated by the central nervous system, specifically by the medulla oblongata and the pons, two structures of the brainstem, and chemoreceptors in the carotid and aortic arteries. The carotid and aortic bodies. The carotid body is a section of the carotid artery wall, and the aortic body is a section of the aortic arch wall, both which contain the chemical receptor sites that detect the decreased blood level known as O2 and known as hypoxemia. When hypoxemia is detected, electrical impulses are generated sent via nerve cells to the medulla, which will increase respiration rate or depth are needed to correct hypoxemia. Okay, inspiration. To affect inspiration, the medulla sends an impulse via the peripheral nerves. So, inspiration equals medulla. Inspiration equals medulla signal via peripheral nerves to the diaphragm. To diaphragm, not muscles, along with intercostal nerves to the intercostal muscles.
telling the muscles to contract. The contraction of the diaphragm causes it to flatten and move downward, while the contraction of the intercostal resulting in pulling the ribs upward and outward, enlarging the thoracic cavity. The contraction causes the diaphragm to flatten and move downward. So we got the okay, so we have in diaphragm, this contracts, diaphragm goes down, intercostal muscles, rib cage bigger, expiration. Once the medulla stops sending motor signals to impulse that cell, the intercostal diaphragm begins to relax. Once again, shrinking the thoracic chest cavity into a smaller pre-inhalation state, compressing the lungs. The elastic tissue of the alveolar we call somewhere like a rubber band, forcing the air that's mostly CO2 out of the air so it can be exhaled and returned to the atmosphere. So what is this? If photosynthesis provides oxygen, this is basically cellular human respiration equals exhalation. So that the human body metabolic process carries the diffuse blood into the lungs. The medulla sends a pulse via the peripheretic nerves to the diaphragm muscle, the peripheretic nerves to the diaphragm muscle, and a signal to the intercostal muscles, telling the muscles to contract. He tells those muscles to contract in the diaphragm. The contraction of the diaphragm causes it to flatten and move downward. So when you contract the diaphragm, contracting and squeeze, aka squeeze, the diaphragm causes it to flatten and move down. Flatten and move downward, while the contraction of intercostal muscles results in pulling the ribs upward, enlarging the thoracic cavity. The medulla will stop sending the motor signals to inhale, impulses to inhale via perinic nerves to diaphragm muscle. The intercostal and diaphragm muscles begin to relax. Once again, the shrinking of the thoracic cavity to the smaller pre-inhalation state and compressing the lungs. This elastic connecting tissue to the ribs recoil somewhat like a rubber band, forcing the CO2 out of the alveoli so it can be exhaled and returned to the atmosphere. Assessing respiration. The only equipment required to assess respiration is a watch with a second hand. Assess the respiration by rate per minute, depth, rhythm, pattern, respiration rate. 1, 2, 3, 4, 5. Because individuals can voluntarily control their breathing for short intervals of time, it's best to assess respirations without the patient's awareness. This may be accomplished by positioning the patient's arm across his or her chest rather than fuel for the radial pulse and hold the pulse site while you assess the first respirations and radial pulse. It will appear that you're simply taking the ravers. This will help you distract the patient from concentrating on his or her breathing while pressing two fingers against the pulse site. Count the respiration rate for 30 seconds. Multiply it by 2 for a 1-minute rate, and continue to palpitate the radial pulse site to assess the pulse rate. If the patient is very ill, respirations can deviate manually from the norm for a full minute. So, for normal rates, patients very ill, respirations can deviate from the norm.
That's assessing rate. Jesus fucking Christ. There's just more and more and more. Okay, what's tomorrow? Okay, let's just take a little break for a second. What are we doing for tomorrow? Okay, we got chapters 4. So 15 pages, documentation. It's probably going to take a couple hours. You have pages 71 to 97. Subtract 18. So subtract 10. Wait. 89, 10, 91, 20, 26? Really? 26 pages of documentation plus 101 to 117, 16, so 16 plus 5, was it 15, the other one? 16 plus 15 plus 26, 15, no, I don't even remember. We have like 70, we'll just say like 26 plus 30. We'll just say like 50 to 70 pages tomorrow of just to be early. And then a couple of chapters, so 3 chapters. So 3 chapters of fundamentals. Hopefully read chapter 7. Chapter 7 and chapter 3. Damn. Damn. It's okay. This is what it's supposed to be like. Okay, what the fuck is chapter 21 about? I have a new physical assessment. Okay. Okay, we'll save that for tonight. That's gonna be literally all fucking night. Let me see. I can finish this 1 hour 28 for how many pages? 1, 2, 3, 4. 4 pages. Okay, we can do that. Okay. This page. This page. This page, this page, this page. Well, we're done. 1, 2, 3, 4, 5, 6, 7 faces. We're gonna do 7 faces. Okay, we can do 7 faces. Rate. So we had so this is gonna be rate. So we have the rate. Each respiration consists of 1 inspiration, 1 expiration. Observe the rise and fall of the chest and abdomen and count the rate. The normal rate for adults is 12 to 20 beats per minute. When the rate, depth, rhythm, and pattern and respiration all fall within normal parameters, Upina.
Upina is normal rest rate. Normal rest rate. Normal parameters. Bradycardia describes low respiration rate, 12 respiration, below 12 respiration rates. Trachopina exceeds 20 respiration rates. When the breathing rate slows, it can result in decreased intake of oxygen, which can result in deficiency of O2. Breathing slows, decrease in oxygen can result in deficiency of O2 tissues and cells. When respiration is ceased or is absent, it's known as apnea. No. You have a brief window of 3 to 5 minutes in which to restore respirations before breathing damage can occur. Because heart and lungs work together to provide circulation of nutrients and oxygen, the factors that affect the heart rate generally affect the respiration rate as well. For example, a fever raises the pulse rate, so it will increase the respiration rate. Breathing speeds up in an attempt to meet the body's increase for metabolic needs and to excess heat. For every 1 degree raise in body temperature, the respiration rate will approximately increase by 4 breaths per minute. Fuck. Okay, so heart rate and respiratory rate are pretty much synergetic. A fever raises the pulse rate, which will also increase the respiratory rate. Breathing speeds up to meet the body's increased metabolic needs. To remove excess heat, for every 1 degree the body rises in temperature. So 1 degree F increase equals 4 equals increase of breaths per minute. Depth. Ugh. The depth of respiration is observed by the amount of chest expansion, which each breath is relative to the volume that is inhaled. The average amount inhaled is between 300 and 500, which is known as the tidal volume, which can be assessed with special equipment. Without special equipment, you can only observe the rise and fall of chest, provide subjective measurements, usually described as shallow, normal, or deep. Jesus fuck. Age. Newborns 30 to 60, infants 20 to 40, children 20 to 30, adolescents 14 to 25, adults 20 to 12. Smoking increases. Heat increases. Cool.
Damn.
Smoking increases environmental stress, increase, decrease, exercise, decrease, pain, decrease, medication, decrease, increase, respiration diseases, increase, metabolic acidosis, increase, acidosis, decreases, internal cranial pressure, decreases,
Respirations. I was supposed to. I got some shit to finish up today. Ay caramba. It's not looking good for the boy. Rhythm and pattern respiration. Respiration is one that is regular or evenly spaced intervals between respiration. When intervals are not consistent, you assess them as irregular. When rhythm is irregular, further assess respirations to determine if respirations fall in certain patterns. Described in table 116. Respiratory effort runs to the respiratory effort amount of work required to breathe. Normally, the act of breathing is effortless and is performed consciously. The individual who has a labored or difficult breathing is said to have dyspnea. So hypoxia is described as tissue. So difficulty breathing is dyspnea. The absence of breath is apnea. Regular breath is eupnea. Okay. Not bad. Which can lead to hypoxemia. Often the patient does not appear to have dyspnea until he exertion of dyspnea only occurs orthopnea. Related characters. Other respiratory assessments go hand in hand with the previously said, including audible sounds. Got the pulse. So what did we get so far? We started with the body temperature. Types of thermometers. We've got the temperatures, fevers, pain. We got the pulse. We figured out what the pulse is. We heard what the pulse does. Types of pulses. We got respiration, dyspnea, all this fun stuff related
Include audible sounds during ventilation. Include audible sounds during ventilation, and breath sounds are oscillated with a stethoscope. Stratosaurus breathing is referred to noisy. It is noisy, snoring, labored respirations are audible without a stethoscope. Noisy breathing. No steth. Adventitious sounds. Abnormal sounds that may be heard when oscillating the lungs with a stethoscope included wheezes, rattles, cracks, rhonica, and what the fuck? Heard when oscillating the lungs with a stethoscope includes wheezing, rattles, cracks, rhonica, and stridor. Wheezes are musical whistling sounds that may be audible without a stethoscope or heard during or adventitious sounds they may be oscillated with the syllable. Cracks or short, choppy, popping, snapping, or raspy sounds that may resemble made by rubber bands of hair. Low pitch rattling or bubbling snoring. Partial obstruction of large areas due to secretion or tumor. Chenier and stroke respiration, so patterns. Chenier respirations begin shallow, gradually increase in depth and frequency to a peak, then begin to decrease in frequency and slow and shallow. This is followed by apnea. Apnea. Sleep apnea. Apnea. Dysapnea. Dyspnea. Disability. Dysfunction. Dyspnea. Apnea. Dyspnea. Orthopnea. Eupnea. Normal. Bradypnea. Respiration below 12. Trachepnea. Respiration above 20. What? It might be normal for children, adults, usually impending death, apnea. Kusama's respiration. But that's not exhalation, that's just apnea, no breath. That's that. So increased rate respiration with long, strong blowing or grunting exhalation. So increased breath, increased. Okay. Diabetic as or renal failure? What? Associated with renal failure? Houseway. Drug overdose? Meningitis and central nervous system disorders? Breathing are grouped as several shallow breaths followed by very long apnea. So, shallow apnea. Variable length. Shallow. It begins shallow, gradually increase with a peak, then decrease. Period of apnea. Increase, decrease with long blowing grunts. Grouped several shallow breaths. Follow by a long voids respiration. Cosmol is so this is but fucking guard. BP is the so we have the five. We have 3 vital signs we should know about. We literally know about these vital signs. Okay. Now it's time to get to blood pressure. All right. Now it's time to get to the real bitch. All right. Oxygen pain assessment. Okay. Blood pressure, baby. Who knew it? BP is the measurement of the pressure tension of blood pushing against the walls of the arteries in the vascular system. The amount of pressure is determined by the combination of the 4 circulatory qualities: strength of heart contraction or pumping action, strength, blood viscosity and thickness of blood, the volume of blood, resistance. We're done respiration, no? That's not bad. Strength of the heart contraction or pumping of the heart. Viscosity or thickness. Blood volume. I haven't really... some of it. Strength of the blood contraction, viscosity, thickness of blood volume, peripheral vascular resistance. The stronger the contraction of the heart, the stronger the contraction, the greater the volume of plump to the arteries. The amount of blood ejected from one contraction is known as the stroke volume. The volume of the pump blood from the heart in a full minute is the cardiac output. The greater the cardiac output, the higher the BP will be. Conversely, the lower the cardiac output, the lower the BP. So a stroke, the amount of blood ejected. So this is all the amount of. Stronger the contraction, the more volume of blood. You're squeezing more out, right? This is known as the stroke volume, the amount of blood that's squeezed out of the heart. The amount of blood pumped from the heart, in a full minute is the cardiac output. Okay, so we have the stroke volume, which is the amount of blood, 1 contraction of the heart. We have the cardiac output, which is 1 minute of the heart pumping. The higher the cardiac output, so the more blood that's being squeezed out per minute,
will lead to a higher blood pressure. The lower the cardiac output, the lower the pressure will be, because you're not squeezing as much liquid to be, to be counteracted. So the more pressure, the more output per minute you have, the more liquid that needs to be counteracted. The less per minute, the less amount that needs to be counteracted. This will equal as pressure. Okay. So stroke volume is one contraction of the heart. A full minute is termed as cardiac output. So when the CO is up, BP is up. CO is down, BP is down. Let's learn why. When the heart contracts, when the heart contraction is weaker or the blood volume is decreased, such cases for dehydration and hemorrhage, the BP will decrease. Some conditions that decrease heart contraction strength include congestive heart failure or myocardial infarction, known as heart attack, which is pretty much a heart embolism, which ultimately damage the heart muscle, rendering contraction of the heart weaker. Pregnancy, on the other hand, increases blood volume. Heart contraction's weaker, blood volume is weaker, BP will decrease. So pregnancy, on the other hand, increases BP. When there's higher fluid volume within the vascular system, BP will naturally rise. During exercise, the heart beats faster in an effort to meet the increased demand of oxygen. As a result, raises the blood pressure. When the arterial walls are non-elastic or constricted, resistance. The BP will increase. An example is arteriosclerosis, otherwise known as osteoporosis, the emptying and the hollowing of bones. Arteriosclerosis, known as hardening of the heart arteries, which is a gradual process that happens to everyone as they progress through the lifespan. Okay. Laboratory and diagnostic connection. Hematocrit implants blood pressure. When there's a higher portion of red blood cells to plasma, the viscosity of the blood increases, which also causes the BP to rise. Higher portion of blood cells to blood plasma, the viscosity of the blood increases, which causes the BP to rise. A diagnostic check known as a hematocrit is the measure of concentration of red blood cells in the plasma. Loss of fluids occurs, such as dehydration, result in higher hematocrit, while overhydration decreases hemorrhagic percentage. Normal ranges follows 68%, 35%, 32%, 36%, or 48%. Okay. Factors affecting blood pressure. Damn, we fucked this page up. 1, 2, 3, 4, 5, 6, 7, 8. This is going to be chunk number 2, though. Come on. We're going to finish this. This is going to be done. Factors of blood pressure. The patient with family history, which means you're genetically predisposed to hypertension, elevated BP, or either circulatory problems, is more likely to develop hypertension than a patient who does not have a family history of circulatory problems. Disease such as diabetes, kidneys also affect BP. Other factors affect the person's bleeding include the following: age, race, exercise, rest, cardiac rhythm, emotions, medications, nicotine, obesity, levels of hydration, hemorrhage, increased intracranial pressure. It's always intracranial pressure. It's always with these fucking intracranial pressure, boys. Why is BP like just 3 pages long? Okay. So, average BP of a newborn is around 40 millimeters of mercury. BP gradually increases throughout lifespan. Age, BP, hypertension tends to have increased incidence in African American males. What the boy, what the fuck? Seriously? Blood pressure is racist. BP is racist. BP is racist. Exertion both cause heart rate, cardiac output, which rises the BP. Rest, when a person's at rest, the parasympathetic system is stimulated, lower the BP. So BP up, BP down, cardiac rhythm naturally lowers during sleep. So night. Directly or indirectly. What does THC do? THC lowers or increase. It's a depressant. High blood pressure is common. There's that word again. Orthostatic hypotension. It's possible to have orthostatic hypotension and still have high blood pressure. Okay. Haha, that's hilarious.
So THC increases. BP. Let's learn. I don't know. Nicotine. BPM. Levels of hydration, dehydration.
Ah, my finger. It hurts. It hurts so fucking bad. Jesus Christ.
Dehy. Overhydrated. Deflation.
Damn, it's 6 hours just passed by. How the fuck? 9 hours actually have passed by. I just been reading, been fucking researching, studying for 10 fucking hours. 9 fucking hours. It's about to be 10. Components of blood pressure reading. So what was this all about? This was all blood pressure, factors that affect blood pressure overall. So the components of BP assessment includes 2 values. Systolic pressure, which the measurement is the force, which is the measurement of force exerted by the blood against the walls of the arteries during contraction of the heart ventricles. During this time, the ventricles are contracted, known as systole, and this is the time where the pressure is at the highest. Diastolic, which is the measurement of which the pressure exerted by the blood on the artery walls while the heart ventricles are not contracting. This is the lower of the 2 pressures. During the time which the ventricles are at rest is known as diastole. So the ventricles at rest, diastole, measurement of blood pressure exerted by the blood of the artery walls while the heart ventricles are not contracting. Pressure exerted by the artery walls while the blood is not pushing. There's a measurement of the force exerted of the blood during the contraction of the ventricles. So systolic pressure is the pressure of the blood. So what we're looking for is the blood pressure in these arterial walls. All right, we're looking for the pressure blood against the arteries. Systolic is with ventricle contraction
diastole is no ventricle contraction. So there's going to be two pressures, the systole over a diastole. For diastolic, the time which the ventricles are at rest is known as diastole. Diastole. Heart, the ventricles at rest is diastole. So blood pressure is just the top of the pressure all the way to the bottom of the pressure. Okay. I like to see this. I like this learning. There's a simple word you can associate which remember the terms relating to states of the heart ventricles. When the ventricles are not contracting is known as diastolic pressure, known equates to downtime. BP is millimeters of mercury and is written as a fraction. If the systolic pressure is 120 millimeters mercury and the diastolic is 72 millimeters of mercury, the BP written is 170 over 72 mercuries, or just 120 over 72. The systolic pressure will always be the highest reading and is documented at the top number of the fraction, with the diastolic pressure written as the bottom. The pulse pressure is the measurement of the difference between the systolic and diastolic. Subtract the smaller number, the diastolic, from the larger number, and the normal range is between 30 to 50 points. A pulse pressure less than 50 or greater than 50 is considered abnormal. A normal pulse pressure of 40 is seen as the BP of a normal pulse pressure of an example of so less than 30 through 50 . The normal range for adult is between 120 and 60 and 120 and 80. When the systolic pressure rises above 120, it's continued to be elevated. 120 systolic is elevated. Hypertension is the term to describe a systolic reading consistent above 130 or a diastolic reading consistent over 80. Hypertension, 120 systolic, 80. To make the medical diagnosis of hypertension elevated must be documented. To make the medical diagnosis of hypertension, elevation must be documented at least 2 or more separate rates occasions. Shh. Ah, my finger! I must massage. Holy shit! My fingers in pain. Everybody's having fun today. I'm just here alone in my house.
blood pressure is assessed with a stethoscope and BP, otherwise known as a sphygmomanometer, which comes with an aneroidal and electrical pulsar manometer or gauge. The aneroid's sphygmomanometer consists of an inflatable rubber bladder that holds air. So BP cuff. A screw and a valve is attached approximately to squeeze the bulb and allow you to fill an empty prayer from the bed as you observe the pressure manometer. The aneroidal gauge must be calibrated every 6 months to remain accurate. So make certain the needle on zero is before using the cuff. And electron has a transducer that uses sound waves to determine the pressure on digital. There's neither a squeezable bulb nor. So we have the tube, the side. This is the blood pressure cuff. We have the bulb, we have the valve, we have the cuff. We have the bladder length, we have the cuff, we have the bladder, which is the internal bladder width. We have the cuff. Okay, nice, very cool, very cool, very cool. What's primary hypertension? We're pretty much done with this bitch. Nice, Abdi. Look at you. We just killed chapters 16 and 17 today. Okay, so this electrosonographer has a transducer. There's neither a squeeze or bulb needed for the scope when using the electric cuff. This sonometer may be mounted on the wall or above the patient's bed with an automatic vital machine, also available with a smaller portable unit. These cuffs also come in different sizes, so the correct size must be used accurately. If the cuff is too large, reading would be enormous. The width of the BP cuff should cover approximately 2/3 of the upper arm. Okay, upper arm. Also, normal, less than 120, less than 80, elevated, 120. Automatic vital machines use the capability to ultimately including. Stethoscope. Ugh. Fuck you, Littman. Fuck Littman. Fuck Littman. Okay. A stethoscope has a sound transmitting chest. Nobody's gonna see that. Hopefully nobody sees that. It's a joke. I'm joking. I don't even know what Littman is. Do I even have guys, I have non-name brand. Non-name brand, okay? I have no official, I don't care about your company. Stethoscopes. So we had the sonometer, which is a stethoscope and a blood pressure cuff. Plus BP equals stethoscope plus BP cuff called
Sphygmomanometer.
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 There we go. A sphygmomanometer. Stethoscope. are sound transmitting chest piece consisting of a bell diaphragm which attaches to a rubber tubing that leads to two hollow metal tubes binaural. B, the concave side is known as the bell, used for oscillating lower pitch sounds. C, the flat side known as the diaphragm, used for oscillating higher pitch sounds. BP, long sound vowel sounds from. So A is just the stethoscope, B is the bell, C is the diaphragm. The earpiece, each earpiece is placed towards the corresponding angle with the ear canal and should point toward the face when stethoscope's in place. The chest piece is placed against the patient's skin. The bell is used to oscillate lower pitch sounds such as heart sounds and other lower frequency sounds, while the flat side is used for higher pitch sounds such as lungs, bell movements, because sometimes heart sounds may be better heard using the diaphragm. Note that some stethoscopes do not have a bell, thus require diaphragms to be used with lower pitch sounds and more pressure for higher pitch sounds. Wait, nobody told me how to use a blood pressure cuff. You gotta be fucking kidding me. We know how stethoscopes work, okay? Very simple. Assessment. BP is normally assessed with the cuff around the upper arm of the stethoscope over the brachial artery at the antecubital site. Brachial artery. So, on the inside of the owner, I spilled yogurt. It's okay. Trying to find my goddamn brachial artery. Literally can't find my brachial artery. I gotta learn how to find it. At the antecubital site or on the inner side of the elbow, it must be performed by wrapping the blade. I can't find this fucking artery. Okay, let's get the notes then.
It helps be performed by wrapping the cuff around the lower arm and placing the scuff over the radial cuff. However, certain conditions prevent you from using this. So, while palpitating the arterial vessels, inflate the cuff up to 80 millimeters per minute. Now continue to slowly pump the pressure about 10 millimeters at a time. So 58, 80, 90, 100, 120, just really tight, no toss, then deflate until I lose the pulse. Rapid pump to 80. Plus 10. Deflate the cuff and deflate the cuff and wait 2 minutes. Place your stethoscope over the arterial pulse and keep the chest piece visibly flat against the patient. Pump the cuff approximately. If you last felt the pulse at 116 pump, puff the cum to 169 until it's comfortable for the patient. It is uncomfortable for the patient and may cause erroneous rate to pump up to 102. So slowly unscrew and release the air from the bladder. So if I stop hearing at, say, 115, I'll go to this. Release the pressure to oh my god. Ugh. Oscillatory gap. When assessing for BP in some patients with hypertension, oscillatory gap. So we've just learned a measurement of BP. How to measure. So what we got? We got blood pressure cuff 1 to 2 inches above the oscillation site with a stethoscope. Inflated up to 80 for an adult. Slowly pump the pressure to 10 each time until you can no longer feel the apical, the brachial artery. So note to you lose the pulse. Deflate the cuff. Wait for 2 minutes. Play with your scope on arterial pulse, brachial pulse, and keep the chest piece on the stethoscope flat on the skin. Approximately. Cuff, so close the cuff. Say I hit it at 115, I lost the pulse. I'll do it to 130 to 140, 135 to 145, and then 135 to 145, no pulse. Keep the stethoscope on. Release the air from 2 to 3 millimeters of of mercury per second. Listening for the first sound. So we're listening for the first sound, which would be the systolic, which would be the needle point. And then we have the diastole, which will be the last needle sound. So the first needle sound and the last needle sound, which represents systolic represents ventricle. What is it? Ventricle contraction. Where is it? Where is the The amount of blood pumped into the heart is known as the stroke volume, the cardiac output. So we're talking about cardiac output. So what's the blood pressure meanings? What are the blood pressure meanings? Systolic. Motherfucker, what does it mean? Pressure. Yeah, we know it's systolic, which is the force of the blood against with the contraction of the heart ventricles. Contraction of heart ventricles. Diastolic, downtime, heart contractions. Okay, so the diastolic represent the no contraction, no ventricle contraction. And then the systolic is ventricle contraction.
Okay, oscillatory gap. When assessing the BP in some patients with hypertension, you may hear. When assessing BP in some patients with hypertension, so we're talking about 120, so 120 to 129 systolic is elevated. 130 to and above. Wait, 130 and above? So 130 and above is high BP. So 130 and above is hypertension. Is that when is it counted as hypertension? Hypertension is above 130. Hypertension 130 over 80. Okay. Which is when it passes those numbers is hypertension. Okay. When assessing patients with some hypertension, you may hear a 30 mercury gap in the carotid sounds. For example, you may hear the first carotid sound beginning at 169, and then hear nothing but silence as the needle drops to 130, which sounds the carotid sound, returning and continuing till you lose them for good at 170. This silence return is known as the oscillatory gap. If you do not adequately inflate the cuff while palpitating, this gap can be missed and erroneously low BP reading. An error of this nature might result in a failure to detect elevated BP that requires treatment. Use caution to palpitate. So the first sound is clear rhythmic tapping as the blood is increasing intensity. The second sound is a swash murmuring as the blood finally gets to go. The third is a sharp, crisp, rhythmic sound. The fourth is a softening muffle, and then fifth is silence. So between fourth and fifth sound is your diastolic. Okay. Using caution, palpate carefully, then inflate the 30 millimeter above that point. If the oscillatory tap is detected, record the number at which it began and ended. A good BP of 170 over 6 with the oscillatory gap between 162 and 138. So 160 over 174 with the oscillatory gap between 162 and 138. But it continues to hear sounds from 138. You continue to hear sounds. So you hear sounds from, you hear the, so you let go, you hear the first sound. So 20 above that would be, you start at 180, you listen, first sound at 162. There is a gap between, there's a 40 millimeter gap between 30 millimeter, actually it's 30 gap between 162 and 138, but then it continues all the way down to 74 and then no sound. Okay, that's not that bad. Hypertension. Normally the arterial walls are elastic and stretch and recoil abilities to accommodate for the changing volume in blood in the cardiovascular system. However, osteoporosis, which basically means hardening of the blood, arterial walls, hardening of the arteries. Hardening of the arteries. Okay. Arteriosclerosis, progresses through the years and gradually the loss of elasticity of the arterial walls. With less stretch and recoil, the heart has to work harder to pump the blood through the cardiovascular system as rigid artery walls increase. The rise of BP is known as primary hypertension or essential hypertension when there's no renal or endocrine disease that results in elevated BP is turned secondary. So primary is caused by arterial cirrhosis, is primary hypertension, or essential hypertension, when there's renal or endocrine, so it's a secondary order of effect. So secondary order of effect hypertension. So this would be caused by the renal or endocrine disease, which is caused by a other pathology. So primary is caused by arteriosclerosis. Secondary is caused by other pathologies that affect hypertension. Which basically means 130 on above 130 diastolic and 80 in general. Okay, hypertension is a widespread problem in the United States. No shit. Hypertension is a widespread problem in the United States because there's a frequently few or no symptoms, it goes undertreated. Thus, it's important to educate your problems, encourage to have annual BP screenings. Also, teach your patients for the risk factors that contribute to hypertension. Treatment of hypertension. Oh my god, my head. Treatment of hypertension usually involves a number of lifestyle changes, such as reducing dietary intake, salt and fat, weight loss, smoking reduction, excessive alcohol intake, stress reduction, increased physical activity, exercise, as well as medications with lifestyle changes are not adequate. Left untreated, hypertension can result in the permanent damage following. Okay, so hypertension's high blood pressure. How does that cause stroke? Because we learned stroke is brain can damage the brain in the form of a stroke, but we know a stroke is a CVA, cerebral vascular accident, but that's caused by an embolism. So someone's going to have to explain to me why hypertension is causing embolisms. I don't know why. Like, high blood pressure causes, like, what? Like, we know embolisms is caused by pooling of blood. How the fuck does hypertension cause embolism? Someone's gonna have to tell me about that. Embolisms. Is it because more blood's being filtered? Who the fuck knows? Heart in the form of heart attack or myocardia. We know that's just a myocardic embolism. Kidneys result in kidney failure. Retinas in the eyes resulting in loss of vision. So hypertension can involve the brain, the heart, the kidneys, the retinas. Risk factors for hypertension in individuals. Risk factors for developing hypertension. Family history of hypertension, smoking, chronic high stress, moderate alcoholic consumption, obesity, elevated cholesterol levels in the body. Okay, hypotension. We have hypertension. Boom, bada bing, hypotension. Oh my god, we're done chapter 17 in less than 18 minutes. No way. We're done. Hypotension. When blood pressure falls 20 to 30 millimeters of mercury below the patient's normal levels of 120/80. It is considered hypotension. However, it is important that some perfectly individuals normally run in low ranges, such as a person with small body build or athletic or in good physical condition. This is the only reason why it's necessary for you to be familiar with your patient's normal range of vital signs. What should be abnormal for one patient and require treatment might be normal for another patient. So, like, okay, so necessary to be familiar with your patient's normal readings because athletes and huge muscle mass equals low BP, but not hypotension, hypotension. Okay. So, normally the peripheral arteries have enough elasticity to recoil. And provide
Okay, and normally the peripheral arteries have enough elasticity and recoil to provide increase in BP to counteract the forces of gravity when a person rises from a lying in a sitting position. In older adults, much of the elasticity has been lost, thus slowing or reducing the constriction of arteries, allowing blood to pool in the lower extremities upon standing. You see, hypotension would make way more sense for myocardial infarction and then CVAs, but apparently it's in hypertension, so maybe they both cause it, who knows. Normally, the peripheral arteries have enough elasticity to recoil in case counteract the forces of gravity when a force rises. So when you get up, that's why you gotta squeeze. So when you get up and you're feeling an orthopedic hypotension event, that means you have to squeeze your abs. So your blood, because by constricting your abs, you're pushing blood up and in. You squeeze your muscles to increase BP. As a result, okay, so anyways, the blood pools lower in the extremities upon standing. As a result, BP drops sometimes, enough dizziness or synocope fainting. We already know that. When positions change results in systolic pressure equal to or greater to 15 millimeters of mercury, or the diastolic pressure falls below 10. This is known as orthostatic hypotension or postural hypotension. Patients who are dehydrated, have anemia, or have been limited to bed rest for extended periods of time, so their blood is pooling, or who are receiving medications such as narcotic androgens, sedatives, and anesthetic medications, or elderly patients are prone to orthostatic hypotension. It is advisable to teach a patient to slowly lift from a reclining position overall several minutes to allow BP to balance after standing up. After he or she has been stood up, you're encouraged to stand for several minutes or before walking away, making sure she or she is not fainting. Okay. If a patient has become faint due to hypotension, the initial treatment is to lay the person in a modified Trendelenburg. Oh my fucking god. No shot. There's another position. Modified what is it called? Dinkelberg. Oh, look at that. You're laying down, but your legs are up. That's another, look at that. We have another position. We got to go all the way back to positions. All the way back to positions. Because they decided to add another position. You motherfuckers. We have Trendelenburg, and then, what do we have? There's reverse. What is this one? Modified. Modified. There's another one. They didn't even put it in here. Fucking bozos. A modified Trendelenburg. You would think the book has a lot, but they've already messed up. Like, how many times I gotta read this and fucking fix your book, you bastards. Okay. If the position faints due to hypotension, the person is laid in modified Trendelenburg. So if we know that Trendelenburg is, we call it CIA torture position, right? We have waterboard position, and then we have actual Trendelenburg. Wait, no. Reverse Trendelenburg, right? Modified is with body but legs straight to return blood. Okay, cool. This is, it's already describing it. This is supine position, which the feet are elevated above the level of the heart. This increases blood flow to the brain. A full Trendelenburg position, where the lower head is lower than the heart, is no longer recommended. Oh wait, this shit's no longer recommended? Didn't it say that? This shit is no longer recommended. Why are they lying? They said it's no longer recommended, but they gave me, okay. Okay, so we're still in hypotension. A serious condition results when hypotension is due to a hemorrhage or shock. So low blood pressure, so hemorrhage, blood loss, shock is necessary. Wait, what the fuck? And extremely serious conditions result when hypotension
is due. So this is extremely conditional results. Extremely serious conditional results when hypotension is due to hemorrhage or shock. Immediate medical prevention is necessary to provide adequate blood supply and oxygen to the life-sustaining organs. Okay, that's blood pressure. Okay, the 5 vital signs. We got, what do we got? We got temperature, right? We got temperature. We got pulse, right? We got respiratory. That's 3. Now we got blood pressure, which is 4. 5 is oxygen saturation. Okay. Number 5. And then pain, the subjective 6. When oxygen enters the blood, it binds with hemoglobin and red blood cells. Oxygen enters the blood supply. It binds with hemoglobin and red blood cells to be transported and made accessible to the blood. Normally 96 to 100 of normally 96% to 100% of hemoglobin in arterial blood is bound with oxygen. So this is hemoglobin bound blood. Hemoglobin bound red blood cells, RBCs. Okay, RBCs is provided. Okay, this saturation level is measured with an look at this. It's right here. We'll do it right now. Even though my thing's kind of fucked. Wait. So 99, 98, and then my pulse rate 769, 68, 73. Okay, that's not as right, but 98 oxygen saturation. That's not bad. Okay. This saturation level is measured with an electronic pulse oximeter attached by plastic clip sensors to the fingertips, the earlobes, or the bridge of the nose, or when circulation is adequate, the toe. Special sensor probes can be applied to the forehead and the palm or the sole of the foot. The LED light transmits, then calculates the measurement of reflected light waves into the monitor, and the pulse saturation. So, what is it called? So, pulse saturation O2, a digital readout, represents the oximeter. It can be applied in red intermittently and can be applied for continual monitoring. The selective assessment should have adequate blood flow and should be clean and dry and moisture that may interfere with accuracy. Artificial nails do not allow arcuate because the LED cannot read through them. Also remove dark fingernail polish to allow for accurate readings. Patient movement also interferes with accuracy. Finger probe assessment are produced in less than 30 seconds and earlobe produced in less than 15 seconds. If the results are below 90, the RN supervisor should be notified and further instructions regarding the oxygen saturation. Okay, that's O2 that was easy compared to like BP and shit. Okay, pain. Okay, so we know pain is why everybody goes to the hospital. It's literally the one vital sign that everybody thinks of. They're like in pain, you go straight to the hospital. It's subjective though. Acute pain is the pain that has sudden onset or may have severe symptoms and runs shorter course than chronic pain, which is longer duration and ongoing. So we have acute pain, we have chronic pain. So we have acute pain, we have chronic pain. Oh, we have 7 minutes. 7 minutes till the stream ends. Hypertension, oxygen saturation, 98 to 96 to 100%. Hypotension. So hypotension is 100 over 60. So hypotension would be 120 to 30. So 20. So 80 to 80 to 70 over 80. So 80 60 to from 60 to 50. So we're talking about basically under 100. So we're looking at, so systolic is, so for the So if it belows, if it goes below 100 over 160, it can be counted as hypotension of the normal ranges. Okay. Pain can be considered one of the vital signs for only a few years, but has been considered one of the vital signs for only a few years. But acute pain has such a dramatic effect on the pulse, respiration, BP, and important to assess pain with the rest of vital signs. Chronic pain does not affect other vital signs the same manner as acute pain. These characteristics of pain can be assessed: site, location, characteristics: sharp, dull, constant, intermittent, stabbing, cramping, burning, severity based on pain scale. Site or location. So it's important to know that it's required where the site of the pain is located. It is easy to assume the patient has been undergoing a surgical surgery on the left leg is having pain in the left leg, when the fact might be that the patient has a headache, a backache from lying on the bed, or abdominal pain related to intestinal. Always ask the location. It is also to note that if the patient may be using terminology different to yours. For example, a patient may deny pain when he is asking if he or she has any pain. Further inquiring, find the patient having discomfort, cramping, or tenderness. Some patients feel that pain is something that is intolerable. Therefore, they're thinking discomfort does not really qualify as pain. Be thorough when assessing your pain. Use more than one term. You might be asking, are you having pain or discomfort anywhere? Okay. Languages. Okay, so subjective. See, because it's subjective, ask more subjects. So it's characteristics. When a patient indicates he or she is having pain, ask for the additional description of pain. Is the pain sharp? Is it dull? Is it cramping or stabbing? The patient's description sometimes help you differentiate between conditions or possible sources of pain. For example, heaviness in the chest, stating that it feels like an elephant standing on my chest, describes a different potential or more serious types of pain experience to the patient, where it says it's only tender when I cough and sneeze. It's only tender when I cough and sneeze. So like a sharp pain in the back of thoracic. So chest, that's okay. So cramping in the chest, that's respiration or blood pressure actually. So we go to respiration. That might be pulse too actually. But pulse is pretty much blood pressure. Oh my god. Your chest, that's mostly respiration though. We'll look at respiration. So what kind of is it? What kind of pain? Absence of breath? Apnea. So there's an apnea going on. If it feels like someone's sitting on your chest, maybe it's bipnea. What is it called? Bipnea. I can't fucking pronounce any like pulmonary disorders. Bradypnea describes rate below 20. So like they're feeling, what does it feel like? What if, okay, but like, isn't there like look at them, aren't there like heart chambers, hypothermia? Where's the one where it said, we don't have much time left. Pain scale. Use a pain scale such as 0 to 10, 0 being no pain and 10 being the worst pain you can imagine when assessing a patient's pain. Because the pain is subjective matter for a patient, use of numerical scales introduction may certain amount of objectivity. After pain medication has been given, it is important to reassess the patient's pain using the same pain scale from before, so you can objectively determine whether or not the medication was effective. So 0, Wong Baker's faces hurts the worst. This part of the evaluation phase of nursing process for younger children with impaired cognition
You'll probably use the Wong Face's pain rating scale, which is a consistent picture showing the varied degrees of discomfort from smiling to frowning to crying. The child can point the picture that matches his or her pain level. The Flax scale of behavioral pain assessment is ranging from 2 month. How the fuck is a 2 month? The Flax scale of behavioral pain assessment tool for pediatric can be ranging from 2 months to 7 years old. This tool can measure 5 different categories: face, leg, activity, cry, consolidability, with scores ranging from 0 to 10. This tool is to be used in conjunction with the assessment of the child. This tool is also used for pediatric cognitive development delays. Vital signs are generally documented on a flow sheet solely for this purpose. Refer to 17 for the simple electronic feat. Most facilities also require that vital signs be documented by the nurses. Note that vital signs are generally documented on the flow sheet.
All right, done chapter 17. In 46 seconds left. Look at that, boys. We did chapter 16. Positioning, all that fun stuff. Let's just look at it again. Let's just look at the pages we did today, okay? Let's just look at the pages. This is the most I've been reading today, okay? We have 10 hours of, almost 9 hours and 58 minutes of work, all right? We have effects of immobility, right? Muscular, skeletal, all that fun stuff. The 7 different systems it affects. We got the immobility, how we freaking fix those, the type of beds, psychological effects, positioning patients, fucking moving and lifting patients, turning patients, patient transfers, all the different type of PDs. We have 7 different PDs. We got fucking transferring these motherfuckers. Excuse my language. Delegation, supervision, and delegation between lifting. You know, make sure correct ambulation, all that fun stuff. We have some of the skills that we'll look at next Wednesday. We have vital signs, the 5 objective and 6 objective. Oh my god. Countdown is done. We're out. Look at that. We're free. All right. Thanks for everybody who showed up. I'll be back later, maybe in a couple hours. I got chapters 21 to finish. I got to read chapters 4 and 6. And then chapters 3 to 1 of pharmacology and 6 of pharmacology. Chapters 6 and 7 of nutrition. And then we'll go back to fundamentals. We'll relook at some of the finishing stuff. And then Sunday, we should wrap up some of the review, hopefully. Really productive day. I'm really happy. So I'll be back maybe a couple hours. Thank you for 3 people who've been watching for however long. I appreciate you and love you. And I hope your day goes very good. And bye.